we just don't give ADT. We always add ADT plus abiraterone, enzalutamide, or even docetaxel. But a recent study found that 43% of patients with MHSPC received only ADT. So we do see in India, many people are using just either archaeectomy or just giving LHRH agonist or antagonist without adding any drug. What is the optimal X therapy is not based on comparative trial evidence, but requires consideration of multiple disease and non-disease parameters. So what are those parameters? When it comes to clinical factors, fitness for chemotherapy is obviously required. Elderly patients may not be fit for chemotherapy. And fitness for AR inhibitors, particularly comorbidities and frailty. If blood sugars are high, sometimes we may not be able to use abiraterone. Cardiac history and liver diseases, sometimes we may have to resort to other than abiraterone. Prior therapy, AR inhibitors in non-metastatic CRPC and non-AR phenotypes. Sometimes we can have associated neuroendocrine tumors, we may have to consider chemotherapy. Low volume disease, less compelling data for docetaxel, and high volume disease, definitely docetaxel is the preferred drug. When visceral mets are there, docetaxel is the preferred drug. And ERI and abiraterone can also be used in that space. So therapeutic decision based on patient preferences. So duration of therapy. When we give chemotherapy, generally it gets over within 4.5 months. So they will continue only with ADT. They don't continue with chemotherapy. And some patients may not like to take either chemotherapy or pills. We need to understand those things. And perceived versus actual quality of life, we don't have any data on that. And in India, definitely economics is going to play a big role. Financial toxicity, definitely we see in most of the patients. But however, the compelling level 1 evidence suggests that majority of MHSPC should receive ADT plus additional agent, which could be abiraterone, enzalutamide, or docetaxel, whatever. That is the standard of care. And even the NCCN recommends one of these drugs should be added to ADT. Sorry, I'm going back. Yeah. Which drug is better? Is there any? We have 3 drugs. Which drug is better? This is the indirect comparison of efficacy between combination approaches. This is a systematic review and network meta-analysis based on 7 clinical trials on MHSPC, evaluating more than 8,000 patients, where enzalutamide and ADT had the lowest absolute hazard ratio compared to ADT only, and an estimated 77% probability that it is the preferred treatment to prolong the overall survival. You can see the hazard ratio of comparing enzalutamide with other drugs. Here again you can see the low volume versus high volume, how enzalutamide is doing. So these are the new developments in MHSPC. Phase 1 trial yesterday we have discussed. I will not go into the details of this. This is the study design. Standard of care was compared against radiotherapy, abiraterone, and in the other arm, abiraterone plus radiotherapy. The baseline characteristics were comparable. I will not go into the details of this. Yesterday we have discussed all these things. Arasens again, daralutamide plus placebo in combination with ADT plus docetaxel. I will skip all these things. So the message for MHSPC is treatment intensification is preferred regardless of how fast or far the PSA falls. The quality of life and patient preference should be considered when choosing these treatment options. Coming to the last one, that is MCRPC setting. We have all these drugs approved by FDA. These are the clinical trials which are ongoing. I will not go into the details of this. This is the CARD trial where cabazitaxel they have used 25 milligram along with prednisolone plus colony stimulating factors versus enzalutamide. So cabazitaxel in this space was superior to AR inhibitors. So therapeutic decision making for MCRPC, earlier movement of primary AR directed therapies, now known pathways resulting in AR resistance limits utility of crossover and current agents. Prior therapies we need to understand, and we should also understand the symptoms, biochemical or ward, radiographic progression, and durability of initial ADT response. All these, based on all these factors, we decide our treatment. This was again discussed yesterday extensively. I will not go into the details of this BRCA1 and BRCA2, all these genetic germline DNA mutations. I will run through my slides. So NCCN definitely recommends the germline mutation testing in patients with prostate cancer when there is a family history of prostate cancer, any of these cancers, when there is a family history of DDR mutations are there, and high risk localized prostate, node positive, that is LAPC, metastatic disease, definitely this germline mutation is needed. PARP inhibitors, yesterday we discussed extensively. I will not go into the details of this. These are the newer developments in MHSPC. PROPEL trial, again we discussed yesterday, olaparib plus abiraterone plus ADT versus placebo plus abiraterone plus ADT. These are the conclusions from PROPEL trial. Addition of olaparib to first line ABI significantly prolonged the radiographic progression-free survival. The median radiographic progression-free survival hazard ratio was 0.66, and investigator concluded that olaparib plus abiraterone is the first combination to demonstrate clinical benefit in first-line MCRPC. Whether it's going to, yesterday Dr. Chirag asked everyone, are you going to change this from Monday onwards? It is not that easy to establish this in Indian patients. This is again vision. We are all using lutetium PSMA in our clinical practice. I will just run through. This is the survival of vision, that is lutetium PSMA. Median overall survival, all randomized patients, it was around 4 months. Survival advantage was there, whereas radiographic progression-free survival around 5 months was there with lutetium PSMA. This is the conclusion. Higher rate of treatment emergent adverse events were also seen more with lutetium PSMA. If the bony metastatic disease burden is higher, lutetium PSMA can cause bone marrow suppression. That's very challenging to treat. These are ongoing trials. This I've already discussed. Thank you. I'm happy to take up any questions on this. Probably I can involve a lot of medical oncologists are also there. If any questions are. Yes, sir. Can you please use your mic?
So can you use the mic to speak in?
So, when we say first thing, first
can you keep the?
We can't hear you.
Hello. What is your idea of reserving these cases, these drugs for once they become biochemical?
There is clear evidence from charted trial, latitude trial. Okay, there is clear evidence. You have to give either abiraterone or docetaxel or enzalutamide along with ADT. There is clear level 1 evidence is there. Many people may not use it, particularly in India. We may not add all these drugs along with ADT. Okay, but there is compelling evidence, level 1 evidence is there. We have to use that. Around 14 to 15 months survival advantage is there. Why you should not be using that? Of course, if you take clinical practice in India, even in Europe, 43% are not using that.
Because the problem is once they progress, then hardly we have anything in the type 2.
No, we have many things. We have many things. As a urologist, generally we use only the drugs, oral drugs. Okay, we generally don't refer them to medical oncology. There are many other options are there. We look only for oral agents and we stop at that level. Ideally, these patients, metastatic CRPC patients, we should discuss in a tumor board where medical oncologists are also there. There are so many options are there. We need to be open and we need to consider all these options. Then only outcomes can be better.
Sir, may I ask you one question? So what is your take on the triple therapy right now?
There is evidence. See, we are one end of the spectrum, we are discussing whether ADT alone is sufficient or not. Actinium therapy is very expensive. Thank you, madam. We can discuss probably later. Thank you.
Yes. Thank you very much, Dr. S.K. Raghunathan, sir. We begin with the abstract presentations on localized renal cancer. And before I invite the first speaker, may I request you all to please stick to the time allotted to you, that is 3 minutes. I invite Dr. Rajesh Reddy, who is a consultant uro-oncologist from Asian Institute of Nephrology and Urology, Hyderabad. He'll be presenting the first 2 abstracts. At the end of first 3 minutes, I'll be ringing a small bell. Thank you.
Can I remove this one? Presenter.
Dissection in patients with non-metastatic renal cell carcinoma who underwent curative nephrectomy. This is a retrospective long-term follow-up multi-center study. This was conducted in, it's a Korean study conducted in 5 hospitals, presented in AUA 2022. The main objective of the study is to evaluate the prognostic impact of lymph node dissection on oncological outcomes in patients with non-metastatic renal cell carcinoma who underwent curative nephrectomy. The oncological outcomes are in terms of recurrence-free survival, cancer-free survival, and overall survival. It's a retrospective 5-center study. Non-metastatic RCC patients who underwent curative nephrectomy between 2000 to 2012 were considered, included in the study. The patients were followed up till the end of 2018. The survival measures were compared according to performance of lymph node dissection and presence of node positivity. The Kaplan-Meier's analysis with long rank test and Cox regression analysis was used for statistical methods. And the results, the median follow-up was 55 months, and 1,328 non-metastatic renal cell carcinoma patients underwent curative nephrectomy included in the study. Among them, the 30% had the recurrences, and overall deaths 15%, and cancer-specific deaths were 14%. Here, sorry for the poor quality. Here, in section is it has got a little bit survival advantage, but when you consider other high-risk pathological features in multivariable analysis, there is no much difference between no lymph node dissection and lymph node dissection. There is one point. And in all terms of oncological outcomes, recurrence-free survival, overall survival, and cancer-specific survival. These are the high-risk pathological features which are adjusted to analyze the patients in multivariate analysis. And the second thing is the lymph node, no lymph node dissection versus lymph node dissection done, but node negative disease, again, there is no survival advantage. However, in patients who underwent lymph node dissection but node positive had a little benefit with lymph node dissection. So the prognostic impact, which is the core, the objective of the study, then the lymph node positive group had significantly worse prognosis, and there is no significant survival difference between no lymph node dissection and lymph node dissection negative patient, done node negative patients. Conclusions are not very clear. I'm going to take home message. In patients with non-metastatic renal cell carcinoma who underwent curative nephrectomy, this is not a practice-changing study, because we already know that no positive renal cell carcinoma has the worst prognosis, and there is not much survival advantage in patients who had no negative disease with lymph node dissection. I am going to second abstract, that is the detrimental effect of frailty status on renal function recovery after partial nephrectomy. It's a long-term result from a prospective surgical cohort. So this is an Italian study, a single center study presented in AUA 2022. The objective, we already know that there are two important factors which can affect the renal function recovery after nephron sparing surgery. Those are parenchymal mass preservation, and second one ischemia. So this study aimed at investigating the role of frailty status on long-term renal function status undergoing patients undergoing nephron sparing surgery. What is frailty index? It is a common medical syndrome in older adults characterized by high risk for falls, diminished strength, endurance, and overall reduced physical functions, physiological functions. So coming to the methods of the study, it's a prospectively maintained database at single tertiary care center was analyzed. Patients treated with nephron sparing surgery for T1 and T2 renal mass were included. eGFR was calculated by CKD EPI formula, and acute kidney injury was defined according to Rifle criteria, and modified frailty index was adopted to identify the frail patients. These are the variables of modified frailty index. Multivariable logistic regression analysis was used for statistical methodology. And the results, overall patients treated with nephron sparing surgery for T1, T2 renal mass disease, the 1,584, among them 17% were frail patients, 273 number. And the frail patients were frequently older and predominantly men. and median preoperative eGFR was lower in frail patients when compared to non-frail patients. Coming to the results, after adjusting the patient and tumor characteristics, the frailty status predicted a high risk of postoperative acute kidney injury. When compared with the non-frail, this is non-frail and this is frail, the immediate postoperative renal function was the lower in frail patients when compared to non-frail patients, and in non-frail patients there is the improvement of renal function recovery over the long-term follow-up of 5 years. Whereas in the frail patients, the renal function was already low, but it is continuously decreasing in trend. So this is one of the important findings which was demonstrated in the study. In conclusion, frail patients are higher risk for developing acute kidney injury after surgery, and improvement of eGFR has been shown in non-frail patients, and opposite effect was observed in frail patients. Take-home message, frailty status is an important predictor of postoperative acute kidney injury as well as long-term renal function recovery in patients undergoing nephron-sparing surgery. So frailty status should be considered in our practice while taking the decision making for nephron-sparing surgery. Thank you.
Thank you, Dr. Rajesh Reddy.
Thank you.
I would like to invite Dr. Manoj Tumala for the next two presentations.
Evaluation of current concepts and a novel approach for high-level IVC tumor thrombus. So the objective of the surgical management for RCC with IVC thrombus is to completely resect the tumor burden, and it may involve the resection of IVC with or without reconstruction. And it also involves lymphadenectomy, which requires a meticulous pre-operative planning and a complex technique. In patients with RCC using both of level 3 and 4 to assess the difficulty in high-risk patients. Prospective analysis from 1971. So comments are there's a retrospective study, and the patients are included from 1971, where the staging of the Mayo Clinic and the AGCC staging has changed a lot. And most of the tumors in IVC thrombus are having a larger tumor burden, and most of them are having ISUP higher grades, and most of them contain a sarcomatoid features. And morbidity and perioperative mortality risks are not negligible and have to be taken into account. Patients we need to choose properly. Age, comorbidities are the most important thing. And there is no good randomized study to compare where there are any IVC thrombus patients having any adjuvant immunotherapy. Is there any benefit or not? Still, there is no study yet to prove. So, thank you. And this is the second abstract. This is on implications of positive surgical margins following a robotic partial nephrectomy. So it's a feasible approach, excising renal tumors of varying complexity while achieving a good oncological and functional outcomes, which is proven. The expanding indications of robotic partial nephrectomy, where we deal with the complex renal masses now, so which raises the concern of margin positivity and efficacy in oncological thing. The study reports the implication of positive surgical margins following RPN. It's a retrospective analysis done in a single center, Cleveland Clinic. So 1,385 patients included from 2009 to 2020. Two cohorts were compared based on the presence of positive surgical margins. All patients had at least 6 months of follow-up, and groups were compared using chi-square for dichotomous variable and t-test for continuous variables. Kaplan-Meier method was performed to calculate the 4-year overall survival rate, and distant metastases were defined as a spread to brain, bone, and lungs. So total 1,385 patients. 1 or 2 patients had positive surgical margin. 1,283 patients had negative surgical margin. All these 1 or 2 patients had higher incidence of history of previous partial nephrectomies, and they have a long warm ischemia time. And pathologically, there is an increased perirenal fat involvement, 3.4 and 12.5, and increased sinus fat invasion and increased lymphovascular invasion, which is significantly seen in positive surgical margin patients. And there is an increase in pathological staging of T3A, 9.6 versus 29.9. Even in oncologically, when they compare to negative surgical margins group at a mean follow-up 55 months, positive surgical margin group had a great overall mortality rate of 18.6 versus 4%, and cancer-specific mortality rate of 7.9 versus 1.6%. So the conclusion is the positive surgical margin on final pathological evaluation is associated with an overall high pathological staging and confers a rate of local recurrence, distant metastasis, and cancer-specific mortality. So described in the literature, it goes about 2 to 8%, and the conflicting evidence concerning the significance of PSM and protection from recurrence is not ensured by negative surgical margins. Frozen section is not done now because of the high false negative rate, and because of the, even though if the positive surgical margins are there, the literature doesn't show there is any change of management at present. And it is mainly associated with high-risk pathological lesion and low surgeon volume. There's no impact on patient survival was noticed, although there seemed to be a tendency to high overall recurrence and local relapse and metastasis in PSM group. Thank you.
Thank you, Dr. Manoj Tumala. Our last 2 abstracts will be presented.
Good morning, everyone. So I'll present 2 abstracts which was presented in AUA 2022. So first is the incidence and significance of 20% decrease from new baseline eGFR after radical or partial nephrectomy. So what is known right now that the new baseline estimated GFR after radical and partial nephrectomy has shown to be associated with non-renal cancer mortality. And in general population, the 20% eGFR decrease from the baseline within 2 years likely to increase overall mortality and risk of ESRD. So with this background, this study was done to evaluate the incidences and risk factor of 20% decrease from new baseline eGFR within 2 years and its impact on overall development of ESRD. So it was a retrospective study, and 38 patients of radical nephrectomy and 369, there is 60% population in this group are partial nephrectomy between 2007 to 2018. And they have defined the new baseline eGFR as eGFR at 1 month after radical or partial nephrectomy. The primary endpoint was 20% decrease of new baseline eGFR within 2 years, and potential risk factor including the surgery type, that is radical versus partial, or assessed by logistic regression analysis. And the secondary endpoint they considered as ESRD, and which was defined by eGFR. So the preoperative eGFR was 69 ml in the overall population, and new baseline eGFR after radical nephrectomy was 44 versus 67 in the partial nephrectomy group. 20% decrease in EGFR within 2 years was seen in 6.1% population, and there was no significant difference between radical versus partial nephrectomy. However, they found a strong correlation between medical comorbidities like diabetic mellitus, proteinuria, and perioperative complication, which they have not defined in this study what complication they refer to as an independent risk factor for decrease in 20% EGFR from new EGFR baseline. And ESRD developed in 10 patients, and there was no difference between radical and partial nephrectomy. However, the patient who had 20% decrease in new baseline GFR after 2 years, 21% of them developed ESRD in 6 years follow-up. So they concluded that approximately 5% patient undergoing radical and partial nephrectomy experienced 20% decrease from new baseline EGFR within 2 years, irrespective of surgery type. Because the incidence of ESRD is significantly higher, that is 1:5 ratio from 20% decrease in new baseline EGFR versus normal GFR, less than 20% decrease. So this patient should be followed up meticulously. So the patient, so quick comment is that patient with comorbidities are at real risk for development of ESRD following partial or radical nephrectomy, rather than it is more of medical CKD rather than the surgical CKD. So that we have to keep in our mind. And this patient with lots of comorbidities like diabetes mellitus, hypertension, they should be followed up carefully with a nephrologist. And we may also look into the histopathological change in the non-tumor renal tissue while we are sending the patient, sending the sample for histopathological to see whether there is any change of CKD. That may be helpful. The second is prior surgical experience and impact on perioperative outcome in robotic assisted partial nephrectomy. Effect of prior surgical experience on perioperative results in robotic radical prostatectomy is well known or reported, but it is not known in robotic partial nephrectomy. So they try to evaluate the impact of prior surgical experiences on outcome of robotic partial nephrectomy. It was a retrospective study. 8 robotic centers has been included and 25 surgeons has participated. More than 2,500 radical robotic partial nephrectomy are included in this study. For each surgeon, the number of prior kidney surgery, pelvic surgeries, and other robotic surgeries are noted. The impact of previous surgical experience per 100 cases on warm ischemia time, major complication, and MIC score, that is margin positivity ischemia, and complication were assessed. And regression analysis were done accounting for age, gender, BMI, ASA, Padawi score, and experience of robotic partial nephrectomy per cases. And approximately the median surgical experience in this group, in this cohort, the surgeons had median experience of more than 140 open and lab kidney surgery, and pelvic surgeries more than 500, including 100 robotic surgeries, and other robotic surgery experience were 23. And MIC criteria were fulfilled in 73% of the cases. Multivariate regression analysis showed lower MIC rate, that's poor outcome, with increasing BMI and increasing Padawi score. The positive impact of high number of open kidney surgeries were not observed in this study. And warm ischemia time and outcome in terms of MIC improvement with surgical experience are seen in robotic partial nephrectomy. That means surgeons having increasing number of robotic partial nephrectomy has better outcome. And the prior laparoscopic kidney surgeries, open and robotic pelvic surgeries has also found to have positive impact on the outcome of robotic partial nephrectomy. The major complication rate increased with higher ASA and Padawi score, and decreased with higher experience of robotic partial nephrectomy. So, could not detect any positive impact of worse experience of open kidney surgery. A higher number of prior laparoscopic and robotic assisted pelvic surgery may be beneficial. All surgeons are really experienced. So I think this study is, all those surgeons having more than 700, 800 cases experience. So this study in this cohort is not really useful, I think. It should have been done in a more resident-based kind of a program, then this might have been useful. And likely, surgical experience likely to improve the subsequent surgeries. Nothing great to take home from this study. Thank you.
Thank you, Dr. Sanjay Surekha. And now for a panel The panelists, Dr. Anil Bradu, who is Chief Consultant Urologist and Director, Excel Urology Centre and Zen Specialty Hospital, Mumbai. Dr. H.S. Pava, who is a Senior Consultant Uro-Oncosurgeon and Urologist at King George's Medical University, Lucknow. Dr. Ananth Krishnan S., who is the Director of Uro-Oncology and Robotic Surgery, Chennai at Urology and Robotics Institute. Dr. Gaurang Shah, who is Senior Urologist at Saifi Hospital, Mumbai. Dr. <silence> who is a Urologic Cancer Surgeon from Pune. Dr. N. Srivatsa, who is a Consultant and Head, Department of Urologic Oncology at Sri Shankar Cancer Hospital and Research Centre, Bangalore. Dr. Narendra Basarge, who is a Senior Consultant and Director, Department of Urology, Vital Super Speciality Hospital, Kolhapur. And Dr. Santosh Menon, who is a Professor Pathology, Tata Memorial Hospital, Mumbai.
Thank you very much, ma'am. And thank you so much for giving this opportunity to me. Well, Santosh, are you feeling the odd one out? So, I think we've had a really good session in terms of the abstracts, which have been really useful to go through. And I would like to compliment the presenters, Dr. Manoj, Dr. Rajesh, and Dr. Sanjay, for having covered up the topic very well and made the job really easy for us over the next half an hour. So, the first study that was presented by Dr. Rajesh was the prognostic significance of lymph node dissection in patients with non-metastatic renal cell carcinoma who underwent curative nephrectomy. And wherein the final conclusions that he made was that in patients with non-metastatic RCC who have a nephrectomy done for a curative intent, the patients who are node positive on lymph node dissection have a worse prognosis. What a big surprise. And in node negative group, whether you do a lymph node dissection or you don't do a lymph node dissection, there is no significant survival difference. So I'll start straight away with Sir Dr. Basarge. What do you think that, what are the indications of lymph node dissection you feel during radical nephrectomy?
This has always has been a debatable issue and, hello, yeah. And to me, I think if the pre-op CT staging or the staging procedure or imaging indicates that there are significant lymph nodes.
Mm-hmm.
Sir, can you hold the mic closer to you because it's getting muffled? Just hold it closer, yeah.
Yeah. And intraoperatively also, if there are significant lymph node, probably then there is a point of doing lymphadenectomy along with the specimen, so that a good staging procedure will be.
Absolutely. Dr. Bird, do you think that there is a therapeutic role in this?
I don't think it's proven to have any therapeutic role so far. It's only more staging and prognostic.
Prognostic group.
And that's all we can actually evaluate from doing the lymph nodes. Of course, the survival, we can only confirm, as I said in prognosis, is that if it is positive, we know that the overall survival is going to be
the poorer. Sir, Dr. Pava, do you have any template in mind when you think of doing a lymph node dissection in this situation, when you find obvious positive lymph nodes on preoperative imaging or intraoperative analysis?
So it has been, I think, clear, like we should go for a regional lymph node dissection only. So there are reports also, I think, with complete lymph node dissection has been shown with the, you can say, the compromised overall survival ratio. So this is definitely carrying only prognostic significance, and regional lymph node dissection in cases when it is clinically palpable or in imaging it is positive. So
do you think, Anant, things are going to change with new immunotherapy and much more options now in renal cell carcinoma coming up as compared to what earlier on we had? We could hardly do anything for patients who did have locally advanced disease, but now with the bunch of stuff coming up, do you feel that lymph node dissection is going to come back in a way?
Now, I've got a couple of points to make. One is the way in which we do a radical nephrectomy. In the right, if we skive on the IVC, and the left, we skive on the aorta. A significant portion of the lymph nodes do come out when we take the specimen out. Mm-hmm. And the other point that I'd like to make is if we can do it safely, a lymphadenectomy, without causing a lot of trouble around. And I think we should be doing it. A reasonably good template. I wouldn't, if it's a right side, I wouldn't go to the para-aortic or something like that, or the left side, I wouldn't go to this side. But if it's safely done, it should be done. And I think there's a definite role for lymphadenectomy because of the fact that you just spoke about immunotherapy and so on. It will make a difference, to be honest. So if safely done, lymphadenectomy should be done. But don't overdo it and get the patient into trouble.
Right. I think that's a great point that you're making. I think things are changing very rapidly, and many of these studies which look at data sets from 10, 20 years back may not be reflecting the same thing that is going to happen now. Unfortunately, we can't afford to wait for another 10 years to figure out what to do now. Dr. Shah, sir, do you feel that there is any role of frozen section in deciding whether you should do a lymph node dissection and what should be the extent of node dissection?
At present, there is no role of frozen section, but it appears that if the enlarged lymph nodes are there and if you do it, it comes out to be positive, then definitely we can do the extended lymph node. Otherwise, just removing and sending it is not going to be any beneficial.
Correct. So if you go into it, you might as well remove everything that you see, at least, which is enlarged. I think that's what the consensus is. I'm going to jump to the next study. I think my 5 minutes have been reduced. Okay. So the next study is that the detrimental effect of frailty status on renal function recovery after partial nephrectomy. Long-term results from a prospective surgical cohort. This was again presented by Dr. Rajesh. And he concluded that frailty status is an important predictor of post-operative AKI as well as long-term renal function recovery in patients undergoing nephron-sparing surgery. And hence, there should be a pre-operative assessment of frailty. And those patients who are found to be frail may benefit from a multidisciplinary approach and involving physicians in their care and pre-operatively as well. Sir, I'm going to ask Dr. Kashyapi, is this something which is very new? I mean,
this is not very new. We generally assess a patient, will he be fit for anything or not, and based on that we take a decision. But this is trying to put it more formally, more objectively.
Absolutely. So patients who have multiple comorbidities are likely to do worse, right?
Yes.
Dr. Srivatsa, now, how do you take into account, this is a complex kind of a situation, how do you take into account the comorbidities on deciding whether you're going to do a nephron sparing approach or whether you're going to do a radical nephrectomy?
No, I think the tumor itself should dictate what we will do rather than the comorbidities. So if a patient is an ideal candidate for doing a partial nephrectomy, we should just offer a partial nephrectomy. We can probably, in complex situations where things are a little dicey, to choose between a partial and radical, then maybe comorbidities will come into play. If the patient has high level of comorbidities, then we should try to make that little extra effort.
So it's a double-edged sword, right? A 70-year-old person with a multiple medical comorbidities probably needs a partial more than a 50-year-old person.
Yeah.
But at the same time has a higher risk of developing complications, right? So any kind of an age cutoff or anything you have in mind, Dr. Basarke, please.
One more impact of this study, or probably the preoperative thinking, is if somebody is doing this type of surgery in a frail patient, in a setup where probably the dialysis facility is not there, probably preoperative counseling that this patient, even though preoperative has a normal renal function, may require dialysis in the postoperative period, especially the frail patients. That type of preoperative counseling and doing the surgery in a setup where dialysis facility is available probably is important.
Absolutely. I think that those are great points, but Dr. Pava, please.
One of the point I wanted to add on, like the case, this is like in this study, what they are comparing, like the age, what you mentioned. So age of this subgroup is 69 versus 60 years in frail in this group.
Yes.
And second, if you are looking into baseline EGFR, that is also on lower side.
Yes.
So in that way, I think it is like we need more comprehensive evaluation of elderly patients, is erratic age group. That is what they are suggesting. So this is not a comparable group. So it's not simply we are saying that frail patients are more prone. So this is a subset of patients which is already prone to these.
Correct. So they are more prone to have loss of renal function due to other factors and like diabetes and hypertension, all those which are already playing on them.
Poor renal reserve.
No, but what Rajesh highlighted was that all these factors were adjusted when they tried to do an analysis, but nevertheless it's quite normal to understand that frail patients will obviously do worse.
Do you have anyone? Do you have an age cutoff? Above 70 only radical nephrectomy, below 60 only partial nephrectomy?
No.
I think we should have an age cutoff, because 75 and above you won't do a partial nephrectomy, a complex partial nephrectomy for a gentleman. What are we achieving? He lived the rest of his life with one kidney and a slight renal function elevation.
No.
Is it worth subjecting him to the extra risk of a partial nephrectomy, a perioperative?
Yeah, so that's
trouble?
a complex question, and I think we can argue it both ways.
No, in fact, there is a study which shows that after doing radical nephrectomy, 6 months, the chances of cardiovascular events are more common compared to nephron saving. So if patient has got a heart problem and all, I think it is better to do partial nephrectomy rather than doing radical
And
nephrectomy.
if he has a heart problem, and would you take the risk of doing a 3-hour partial nephrectomy versus a 1-hour lap radical nephrectomy and get it done and over with?
If he is fit, otherwise fit, it doesn't mean that he is at the end stage, you know.
I'm actually with you, sir, because I do believe that there should not be a definitive age cutoff. In fact, my colleague, Dr. Gopal Sharma, did analysis of the Vatiquity VCQI database. I see a lot of authors here of this particular, including you, Anand.
Another point would be asking the pathologist to report if there is associated medical renal disease along with the tumor.
And that's the next question that I have for in the next paper, but I'll ask you right now because sir brought it up right now. So how closely do you watch the adjacent tissue when we send a specimen for radical nephrectomy?
So in radical, we do take sections from the native kidney and we do try to see changes mainly of hypertension and diabetes because those are the two common prevailing conditions, comorbid conditions. So unfortunately, if it is not a full-blown diabetic changes in the kidney, it's difficult to pick. And obviously depends on the age of the patient, how long he has been diabetic. But we do try to. The problem comes in partial cases where we have very little normal parenchyma left.
Right.
So you have to have at least 5 to 10 millimeter of tissue of normal parenchyma to comment on those changes.
And in your experience, Santosh, do these changes vary from one particular part of kidney to the other part of kidney?
So generally, diabetes and hypertension should be diffusely involved in the kidney. Those are systemic diseases and they will affect. So they can be partial. Certain changes in glomerular synovial may be very focal in diabetes and all. But arteriosclerosis like in hypertension should be generally seen. But the problem comes in partial.
Even with a small thin rim of normal tissue in partial nephrectomy, you will be able to figure out what's going on with the rest of the kidney.
5 millimeter is
5 millimeter is what you
generally,
want.
that's what.
And have you ever received any kind of a feedback from any urologist or any nephrologist that, okay, these were the changes that you have mentioned in the partial nephrectomy specimen, what's going on? Any conversation ever?
No.
Yeah, because I am as guilty as anybody else because I have never called up my
no conversation with the
urologist.
urologist.
But maybe this is something to look at, that what are, maybe we can look at these areas and try to figure out what's going to happen after 1 or 2
There are
years.
centers in the US which would do extensive workup of the adjacent kidney, do IgA immunohistochemistry to look at IgA nephropathies and other type of complement nephropathies. They do routinely do native kidneys to do that.
And do you think that that is something that is going to make a real world difference in our set of patients if we do that analysis?
It might, because in elderly and geriatric patient it may help. But the point is, in any case, these patients are on follow with nephrologists. So I think those things would be picked up in any case.
Absolutely, great point. So in this particular study which Anand published, he found that even in elderly patients you could achieve good outcomes provided, and of course this is a highly selected group of patients and it's possible that people who were really sick were not taken up for a partial nephrectomy. But this looked at almost 2,500 patients across countries, across institutions to validate the safety and effectiveness of partial nephrectomy in elderly patients. I'll jump on to the next paper. This is about IVC invasion, high-level IVC thrombus T3B, T3C disease, which is basically below and or above the level of the diaphragm with the involvement of the thrombus. So it was found that in this patient, this was presented by Dr. Manoj, and it was found that in patients with T3B or T3C RCC, the overall survival is associated with lymph node positivity and perinephric fat involvement and not the tumor thrombus level. Again, I think that this is something which we already know. I have 2-3 quick questions for my expert panel here. The first question is for Dr. Pava. What do you think is the best way to diagnose the level of tumor thrombus?
So I think this MRI is good sensitive test. It is non-invasive, and if needed, like we are going for angiography, then definitely you can further.
Dr. Brado, do you think that there is any role of intraoperative monitoring? Do you think that's better than doing an MRI?
Rare cases, yes, but I think MRI by and large will give you good information preoperatively for you to design and plan your surgery.
Absolutely. I think that's a great idea. I'm going to put this question to Srivatsa. Tell me, now this patient comes otherwise fit, doing well, a few, half centimeter multiple nodules in the lung, no other sign of metastasis. Your nuclear medicine expert says that there are mets in the lungs, or the radiologist says there are mets in the lungs, and there is a T3b or a T3c level tumor thrombus. Medical treatment or surgery with IVC thrombectomy?
I think he will still fall into the favorable risk category based on the IMDC risk stratification. I will probably go ahead with doing I wouldn't call it radical, I would call it cytoreductive nephrectomy, but then I will probably complete by doing the entire resection, not leaving behind the thrombus as well.
Okay. And if there are extensive metastasis? Probably
will not do it.
Okay. So basically you'll use the same criteria that you would use when you're doing a cytoreductive nephrectomy with or without a tumor thrombus. Dr. Kashyap, have you had any experience, and I'm going to draw in Raghu here. Raghu is here? No, I think he's here. I'm going to draw you into this because we've had a long discussion about this. But first, the question is for you, sir, that the use of IVC filter.
I haven't used.
Anybody in the panel? Raghu and Srivatsa.
So we have been using IVC filters way back since 2012. More than 100 patients already collectively, and we use it for level 1 and level 2 thrombi because we need a clear 6 centimeter gap between the right atrium and the proximal extent of the thrombus to deploy the filter. Initially we used non-retrievable kind of umbrella filters. Now we use the Denali filters which can be just retrieved in the post-operative period. The rationale behind using them was loss of 2 patients because of intraoperative thromboembolic events. Though IVC filter, I must say, will supplant a carefully done surgery, it will add to that additional safety. So the argument was that only 2.5% of road traffic accidents without a helmet eventually succumb to injury, but we make sure that everybody wears a helmet. So this is an additional step that we can actually take.
How much degree of complexity it adds to the entire pre-operative
30 minutes of extra procedure time by the IR. Cost is about, with the retrievable filters, the cost is around 70. The filter costs about 40,000. In my institute, it's an additional 30,000. In a HCG, probably maybe a lakh or 1,20,000 rupees, not more than that.
Precaution well worth taking, you would agree?
Yeah, definitely.
Absolutely. Any counters to this? Anybody who says that it should not be done? Too expensive?
I think,
not needed?
Yeah, we have tried and we found it is, in cases where you feel it is most useful, it is difficult to place. In a more higher thrombus, it is very difficult to place. You need, as you said, a good number of length of IBC to be clear to put this. So when we felt it is really important, we are not able to put it. So this is one point I want to add.
I think Dr. Srivastava made a very important point of having those 6 centimeters thing. We've tried to put filter in a couple of patients, but the lower end of the filter comes so close to your incision. Sometimes it becomes very difficult to get the thrombus out, especially if it's, going very close to the hepatic veins or something like that. And then even if it's a retrievable filter, of course you can do that, but that creates a problem.
Raghu, just clarify for me, if you have this, so the ones which are going up to the hepatic veins and even beyond can be tackled with the filter?
It's very difficult. The length of the filter, the retrievable filter is 4 centimeters. Okay. If you just deploy that just below the hepatic veins, the upper end of the filter will be almost in the atrium. It can create some,
So it has to be, the thrombus has to be below the hepatic veins.
Exactly. And that is number one. Another point is, once you deploy that one, you should have a sufficient, at least 2 centimeters free length of IVC, where if you're planning to clamp that,
clamp it.
Otherwise, you can't clamp just over the filter. You can damage the IVC.
Yeah, and some people, to counter that, to play the devil's advocate, would argue that it's the higher thrombi which are more likely to break off.
Contrary to the popular belief, it's the level 1 and level 2 thrombi which can have a tendency to fracture and migrate. Higher thrombi will probably occupy a higher level of the IVC. Chances
And there is data to show this. The point that you are making, there is data to show this, that the lower thrombi break off more easily.
There is no data to show that.
Yeah, so it's an assumption. Gagan, like I am assuming, you are also assuming.
Gagan, can I comment on that?
Please.
I have seen 3 deaths. Fortunately, I mean, it happened with some other surgeons. Even the renal vein thrombus in a 20-year-old boy,
yes.
Okay, just by mobilizing the kidney, it flew.
Sir, he has seen, I have created 1 death.
Yes.
So,
we all have our horror stories. Sanjay, I'm going to stop you for 1 second because I have to discuss your papers. So now, implications of positive surgical margins. Well, I'm just going to say that I feel complex tumors are more likely to have positive surgical margins, and that is definitely true. I think we've written one more paper on this, and VCQI database, where there are a lot of co-authors who have contributed to this from all over the world. And we found that positive surgical margins in about 2,500 in patients who got complex renal masses are to the tune of about 10%. Obviously, these patients are likely to do worse in terms of the outcomes, and the chances of recurrence and all will also be higher in these group of patients. So now, one of the things that I wanted to ask Sir, Dr. Basarge, is that do you feel that, how do you take into account the tumor characteristics while deciding whether you're going to do a radical or a partial nephrectomy? What are the 2-3 things that you will look at?
The location of the tumor is one of the important criteria, location and the size, and its extent into the renal hilum and the proximity to the renal sinus. Probably, and of course the surgical expertise of a particular surgeon.
Dr. Shah, would you say that there is a role of frozen section nowadays?
Pardon?
A role of frozen section while doing a partial nephrectomy?
Frozen section, there is no role of.
What are the things that you feel are against doing a routine frozen section? Why would you not do a frozen section if it gives you the confidence that there is?
See, first of all, the false negative or false positive. Second thing is the amount of time. Once we send it, we already close it and we open up the vessels. So again, to go inside and do the surgery for the positive margin, it is not worth.
Absolutely. And I think to a large extent, well, you can actually look at the capsule and identify if there are any suspicious areas and use it more selectively otherwise. Santosh, I'm going to come back to you. You get a lot of frozen sections from
I think
Gagan
last
and
7-8 years I have not seen a single frozen for partial nephrectomy.
Suppose you did get.
Yeah.
How easy for you would it be to identify that whether there is tumor there or not? Very easy, difficult?
It's a little difficult because see, especially conventional RCC, they are full of fat, they have contained fat, and fat freezes very badly in frozen section. So the morphology becomes very difficult sometimes. But given the fact that many times clearly a gross margin can be very clearly seen in some of these tumors. So gross identification is as sort of good as microscopic. The false negative is in, and we know that in any case it's not going to change the management in most of the cases.
Correct.
So I think last 7-8 years, Mahindra and Aman and Ganesh will agree that we have hardly seen any frozen sections.
So I think that is pretty much the practice everywhere. Nowadays, frozen sections have been dropped from...
Gagan, I have a comment to make.
Please, Anand.
Now, the concept of enucleation of tumors, I think it's coming up now. Even the EAU has suggested in certain cases you can do an enucleation. But I would like to put this across to Santosh Menon sir. I think in about 15% of the cases, the pseudocapsule is infiltrated and goes into the renal parenchyma by renal tumor as well, especially common in papillary tumors. So I'm not sure enucleation versus enuclear resection should be accepted.
Absolutely, but I'm going to leave this discussion for another day. I think that's a very important point that you brought out though. So enuclear resection, I think, is what most of us do when we do a partial nephrectomy. Now coming to Sanjoy's papers, which he talked about incidence and significance of 20% decrease from new baseline estimated GFR. It took me a lot of time to wrap my hand around it. So the new baseline eGFR is basically the GFR that you will get 1 month after doing a partial or a radical nephrectomy. And if there is a further decrease of 20% within 2 years after this, that means that these patients are more likely to develop ESRD. Dr. Basarge, do you feel that this is anything new in this?
Dr. Sanjay, the pre-operative GFR was 69, I think, average GFR.
It didn't matter. Whether it's a radical nephrectomy, it was 44. So in a pre-operative GFR was 69, post-op for partial nephrectomy was 44, post-op for radical nephrectomy was 67.
No,
sorry, reverse.
What is my contention is, pre-operatively they are in the CKD stage 1.
So I think this just tells us that those patients who have multiple medical issues, including proteinuria and diabetes, are more prone to have a further loss of renal function over a period of time. And that these are the patients. When would you involve a nephrologist in the follow-up, Dr. Pava? Dr. ʬagship, after that I would want your comment on this.
I think first of all, we should stratify high-risk patients, and early involvement of nephrologist is always good in these cases. If we are suspecting like patient is having comorbidities and age is on higher side. So if we presuming poor renal reserve.
Do you send these patients pre-operatively, sir, Dr. ʬagship? Or post-op?
I would get everybody's GFR, DTPS scan prior. It may not be done in many patients just based on the creatinine value. I think there we may falter. So if I find the GFR is low, I would do get them a consult from a nephrologist.
Absolutely.
At least I will counsel them that you are likely to need this.
That's a great idea. From a medical legal perspective, from patient's perspective, for long-term health, absolutely.
This data doesn't correlate with our donor nephrectomy data.
We'll talk about that. So now when we go to the last paper that Sanjay presented, so more the experience of a surgeon, better the outcomes are, right? I mean, not a surprise. But Anand, open kidney surgery doesn't help at all. It's just, if you do a lot of robotic prostates, you'll do better robotic partial nephrectomy. But if you've done a ton of open partial nephrectomies, it doesn't make you a better robotic partial nephrectomy surgeon. Does it make any sense to you?
Yeah, I'm not sure I agree with that. I think all surgical experience is experience. Yes, so if you have to be a good open surgeon to be a good robotic surgeon or a lap surgeon. So
I agree. So if open pelvic surgery and laparoscopic pelvic surgery make you a better robotic partial nephrectomy surgeon, what it basically means is that the more numbers that you have under the belt, the more time you have spent on the pitch, irrespective of whether you are playing in Perth or in Mumbai or in Sydney, the better you will be able to face the ball the next time you go on the table, on the pitch. Is that right? Does everybody agree?
Not on Perth.
Right. So one final question from Dr. Srivatsa. What are the things that you had to learn or unlearn when you picked up the robot for the first time?
I really can't think of any particular things, to be very honest.
Anybody, Dr. Gaurang Shah, sir, lots of laparoscopic experience, lots of open experience. Did you think that there were some factors which helped you in becoming a better robotic surgeon, or some factors which actually took away from it?
Yeah, see, if you have not done laparoscopic surgery, you always have a phobia starting from placement of the pots and everything, that how you are going to put, where you are going to put. So you have to do laparoscopic surgery, which will help you in initial stages. And at the same time, if you are not confident with the open surgery, then something goes wrong, then you are gone. You have to call someone else to do. So I think there is a combination of all the two surgeries which ultimately helps you in robotic surgery.
Fantastic. I think that's a good way to wrap up this show. Thank you very much for this opportunity, and I'm really grateful to my eminent panelists for giving their excellent views and making this session hopefully interesting. Thank you.
Thank you very much, Dr. Gagan Gautam. Can we have a picture, please, with the panel? The interesting discussion can continue over a cup of tea or coffee. So we now have a coffee break. Please be back within 10 minutes when we resume our sessions. We are already 5 minutes to 10 minutes late, so I will be starting the session early. Please hear my bell and respond to it. Thank you very much. After localized renal cancer, we move on to the locally advanced renal cancer. I welcome the chairpersons again, Dr. Sangeeta Desai, Dr. Nagraj, Dr. Baman Dabar, to chair this session again. The first two abstracts will be presented by Dr. Ritesh Pruthi, who is a senior consultant surgical oncologist from Max Hospital, Mohali. I invite Dr. Ritesh to begin with his presentations. You have 6 minutes, sir, to present the first two abstracts. Thank you.
Good morning, everyone. First, I'd like to thank the organizers for giving me this opportunity. So I've got two abstracts or posters. So the first one is from Milan, Italy. Oncological outcomes in patients diagnosed with PT3A N0M0 renal cell cancer according to renal vein thrombus or fat invasion. So we all know the natural history of patients with PT3A non-metastatic renal cell carcinoma is extremely heterogeneous. After Keynote 564 trial report, such heterogeneity has special implications for follow-up schedule and enrollment in trial testing adjuvant agents. The aim of the study was to investigate the differential prognosis of PT3A subtypes. Now, 426 consecutive post-radical nephrectomy PT3A RCC patients from single institution prospective database were stratified according to PT3A subtypes as perirenal fat invasion only, sinus fat invasion only, segmental or renal vein thrombus only, or at least two of these three factors. Cancer-specific survival, progression-free survival, and relapse-free survival were calculated. Analysis was done with Cox regression models adjusted for tumor size, presence of necrosis, sarcomatoid features, and grade of the tumor. Of the total 426 patients, 15% patients presented with renal or segmental vein thrombus only, 42% had perirenal fat invasion, 21% with sinus fat invasion only, and 22% had at least two of the three features. At the median follow-up of 5.4 years, 33% had distant progression, 4% had local recurrence, and 21% had died due to renal cell carcinoma. Now looking at the Kaplan-Meier curves, the presence of at least two PT3A features was associated with a higher risk of progression, a higher recurrence rate, and higher cancer-specific mortality compared to the presence of only one PT3A subtype. And finally, the presence of perirenal fat invasion was associated to a lower cancer-specific survival compared to sinus fat invasion or tumor thrombus only. To conclude, concurrent presence of perirenal or sinus fat invasion or renal segmental thrombus determined a higher risk of progression, relapse, and cancer-specific mortality. Perirenal fat infiltration harbors slightly poorer outcome relative to sinus fat invasion or tumoral thrombus only. And these findings can improve candidate selection for adjuvant therapy in PT3A renal cell carcinoma. So going on to the second poster, the role of combined sarcopenia and albumin in the surgical prognostication of locally advanced renal cell carcinoma with venous tumor thrombosis. This was by Middenberg et al. From Atlanta. Baseline evaluation of skeletal muscle index and serum albumin have demonstrated value in preoperative risk assessment of patients with renal cell carcinoma. Authors hypothesized that sarcopenia, which was defined as critical deficiency of skeletal muscle mass, and hypoalbuminemia, albumin less than 3.5, will be associated with decreased overall survival and cancer-specific survival in non-metastatic RCC patients undergoing radical nephrectomy with tumor thrombectomy. 103 non-metastatic renal cell carcinoma patients who underwent radical nephrectomy with tumor thrombectomy from 2005 to 2020 were taken from the retrospective database. Body mass index and gender stratified sarcopenia thresholds were calculated. The first group, BMI less than 30, SMI less than 47 for males and SMI less than 38 for females. In the second subset, BMI more than 30, SMI less than 54 for males and SMI less than 47 for females. Now, sarcopenia and albumin risk groups were created based on their individual hazard ratios in univariable analysis and defined as low risk, which is no sarcopenia, normal albumin, medium risk, only hypoalbuminemia, high risk, sarcopenia only, and very high risk, which included both sarcopenia and hypoalbuminemia. Multivariable and Kaplan-Meier analysis were used to determine associations between independent and combined sarcopenia and hypoalbuminemia with overall survival and cancer-specific survival. 51.2% patients had sarcopenia and 44.7% had hypoalbuminemia preoperatively. Sarcopenia was significantly associated with decreased overall survival and cancer-specific survival. There was no relationship between hypoalbuminemia and overall survival and cancer-specific survival. So combined sarcopenia and albumin risk groups were significantly associated with decreased overall survival and cancer-specific survival. Kaplan-Meier curve showed a stepwise decline in median overall survival and cancer-specific survival times with increasing risk. To conclude, simultaneous preoperative sarcopenia and hypoalbuminemia conveyed nearly a 7-fold decrease in overall survival and cancer-specific survival in patients undergoing surgery for non-metastatic RCC with venous thrombus and nutritional status. It does not only helps in early post-operative recovery, but it is also determining the overall survival and cancer-specific survival. Thank you.
Thank you very much, Dr. Ritesh Pruthi. I now invite Dr. Vivek Venkat to present the next two abstracts from Mumbai.
Okay. Good morning, everyone. I'll be presenting two abstracts. The first is C-reactive protein kinetics, which to predict recurrence after radical surgery for high-risk carcinoma, renal cell carcinoma, which was a moderated poster at the AUA. So they wanted to verify the predictive value of perioperative CRP kinetics on RCC recurrence, and they believe that this may serve as a biomarker for the newer available adjuvant options. So this was a retrospective two-institution study from 2008 to 2020. They included patients PT3 and above, note N0 to N2, and non-metastatic disease. So they classified the CRP as normal, less than 0.5 or high, and post-op as normalized or not normalized. And the recurrence-free survival between both groups was compared, and a multivariate Cox model for RFS was done. And they also used a C-index to predict RFS with and without CRP being added to existing models. So what they found was RFS was significantly shorter in those with a baseline high CRP and also in those in whom the CRP did not normalize after surgery. So this proved significant even on multivariate analysis. And when they added it to the C-index for the existing models, Karakiewicz and UISS, there was a modest increase in the predictive value of recurrence-free survival. So they concluded that CRP kinetics may predict RCC recurrence after surgery and may aid in decision-making for adjuvant systemic therapy. So we all know RCC is quite a mysterious tumor. It secretes a lot of things, and a lot of biomarkers have been studied, right from platelet count, NC ratio, numerous things, and a lot of systems are also available. CRP is one such additional marker. It may have added 0.2, 0.02 in terms of the benefit to existing models, but I think it needs further validation in larger cohorts. And instead of complicating existing systems, if we can simplify them to just 1 or 2 markers, which will give us an idea on recurrence-free survival rather than using 5, 6, 7 markers, I think those are more likely to be used in order to predict the need for adjuvant therapy, as opposed to complicating existing systems. And also whether we actually do CRP routinely preoperatively is something that we need to think about. So to my mind, it was not that significant a paper. Anatomic location of lymphadenopathy at imaging predicts the risk of lymph node invasion at final pathology in patients with RCC. That was the second paper presented by Rosiello et al. At the AUA. So the positive predictive value of imaging in detecting pathologically confirmed lymph node invasion in patients with RCC is quite low. It's only from 33 to 56% on previous studies. And the aim of this study was to evaluate whether you could predict the final pathology based on the location of the suspicious lymph nodes at the time of preoperative imaging. So this was a database study of 1,408 patients at a single center from 2000 to 2021, and they defined lymphadenopathy significant on imaging as that more than 1 centimeter. And it was then classified as hilar, intra-aortocaval, para-aortic, or retrocaval based on the location on the scan. And then they performed a multivariate regression to see if it predicted the final pathology. So a total of about 18% had lymphadenopathy on imaging. Median tumor size was 7 centimeters. Median number of lymph nodes removed was 5. And the location was para-aortic in 67%, intra-aortocaval 35%, 27% hilar, and 16% retrocaval. And they then looked at the concordance rate, which showed that para-aortic intra-aortocaval had a relatively low concordance rate, and hilar and retrocaval had a higher concordance rate. That means that if they were positive on preoperative imaging, it was more likely that they would be positive on the final pathology if lymph nodes in the hilar and retrocaval region were enlarged. So they concluded that concordance varies according to the location of the lymphadenopathy. Hilar and retrocaval lymphadenopathies were associated with a higher concordance, and therefore if you perform a more extended lymph node dissection in those which have a hilar and retrocaval lymph nodes, you may have a better idea of classification and planning for adjuvant treatments. So I think we just had the role in RCC still is controversial. This study does add some information, but what exactly was the lymphadenectomy they did? We don't have the full paper, so how many lymph nodes were they aiming to remove? What was the template they used? And of course, further well-designed trials would be needed to answer this question. And as we discussed in the panel, the role of adjuvant therapy is increasing, so this would be an important question to answer in the future. Thank you.
Thank you, Dr. Vivek Venkat. Two abstracts. Thank you.
Yeah, very good morning, everyone. So the first abstract here is about surgical management and oncological outcomes for local retroperitoneal only recurrence for RCC patients after a radical nephrectomy. So only a local RP recurrence following radical nephrectomy, it is a therapeutic challenge. We do not know whether we go in and operate again, we give some neoadjuvant therapy and then operate. So the aim of this study was to assess the oncological outcomes and the prognostic factors for such patients. So it was a multi-center study in China, retrospective over 12 years, and they had 182 patients. They collected clinicopathological data and also perioperative complications, and they determined the cancer-specific survival for these patients. What they found was that the median time from the radical nephrectomy to the retroperitoneal recurrence was 2 years, which is very decent, which inherently tells us that these were probably a better cohort of patients. The median follow-up after the resection of the recurrence was also a very decent 4 years. Distant METs still happened in 62% of the patients after the recurrence of the retroperitoneal recurrence. Now, the time to the appearance of these distant METs is not written in the abstract. The cancer-specific survival at 1 year was 93%, 3 years 76%, 5 years 70%. This is a little dismal compared to patients who do not have a retroperitoneal recurrence. They also used neoadjuvant targeted therapy in 13% and adjuvant in 35% of the patients. Then they determined factors for cancer-specific mortality. What they found was these 3 factors were significant. mixed type of RP recurrence. This is what is written in the abstract. I'm not too sure what mixed means. Maximum diameter of the lesion, the actual size was still not written in the abstract, the cutoff size. And absence of adjuvant targeted therapy. We are still debating about whether adjuvant therapy should be given or not in RCCs after radical nephrectomy, but they found that after resecting a retroperitoneal recurrence, giving adjuvant therapy was of benefit. So they concluded that surgical resection of retroperitoneal recurrence after the radical nephrectomy has optimal oncological outcomes, okay, acceptable complications in the abstract. And this said that adjuvant targeted. So, retroperitoneal only case. What we need to take into account is initially the original new adjuvant, whether it was good. What in the HPR, and did the earlier surgeon do time to recurrence? A patient coming back to you with a recurrence in 6 months, you do not even years, you know it's a good patient. Retroperitoneal recurrence with a single lung met, and you could still take care of both difficult surgical planes because it's go to the second. It's about pembrolizumab as post-nephrectomy adjuvant therapy for RCC. 30-month follow-up from the so-called landmark Keynote-564 trial. So Keynote-564 was a multicentric randomized phase 3 RCT. It looked at giving adjuvant pembrolizumab to patients after they have undergone a nephrectomy in high-risk patients. We'll see what high-risk means. We already have a publication in August 2021 published in NEGM of a 24-month, that is a 2-year follow-up, where they said that there was a DFS benefit from 68% with a placebo to 77% with adjuvant pembro. OS data at that time was not mature. Now they have presented a 30-month follow-up, so 6 months added to the 24-month follow-up for efficacy and safety. So they had RCC patients who were at intermediate risk of recurrence, so a PT2 with grade 4, PT3, ignore the other 3, with any grade, and patients with high risk of recurrence, that is PT4 with any grade, N+ patients, or M1 patients in whom you have done the nephrectomy as well as taken care of the site of metastasis and rendered them NED, that is no evidence of disease. So 2 arms, one receiving placebo, one receiving adjuvant pembro for 1 year, and the primary endpoint was disease-free survival. Multiple secondary endpoints were described. So they had a good number of patients, 500 in each arm. There was a DFS benefit in the 24-month study, and it was maintained in the 30-month study. 75% at 30 months in the pembro arm compared to 65% sorry, in the placebo arm. And this benefit was consistent across all risk groups. So the intermediate risk groups, the high risk groups, they also looked at PDL1 identified in patients, and the benefit was consistent. Additional events were still required to comment on an OS benefit. So they have to have 200 deaths to comment on an OS benefit. Till now, they've only had 66 deaths, so they could not comment on the OS benefit. And there was no additional increase in adverse events as compared to the 24-month paper that they had published. So they concluded that at 30 months follow-up, adjuvant pembro continues to have a significant DFS benefit. This pembro is given at 200 mg every 3 weeks. 100 mg in India costs 2 lakhs. So per injection, it is 4 lakhs. 1 year, 17 injections, 68 lakh rupees for a DFS benefit of 10% with an OS benefit not known. If the patient can pay for it, you have to offer it to the patient because it is mentioned in the guidelines. I'm not too sure how many of us sitting here can afford it. Also, in the recent ESMO 2022, we had 3 more abstracts presented with adjuvant atezolizumab, adjuvant nivo-ipi, and they did not even show DFS benefit. Now, it will be very interesting to see, the full papers of those abstracts to know what was the patient population in those papers, because a T2 disease with a grade 4 is probably more aggressive than a T3A with some perinephric fat involvement, but the grade 2. So it's important to see what is the patient population in these papers. Thank you so much.
Thank you, Dr. Amandeep Arora. We now have a panel discussion on these abstracts which have been presented. And I invite as moderator Dr. Sanjay Adla, who is a consultant uro-oncologist at Apollo Cancer Institute, Hyderabad. I also invite the panelists, Dr. Keval Patel, who is a consultant uro-oncologist from Gujarat Cancer and Research Institute, Ahmedabad. Dr. Mahendra Pal, who is a professor in uro-oncology at Tata Memorial Hospital, Mumbai. Dr. S.K. Raghunath, who is the director and head of the Urologic Oncology and Robotic Surgery, HCG Cancer Hospital, Bangalore. Dr. Santoshi N., who is the director of Urology, Uro-Oncology and Robotic Surgery at Sir H.N. Reliance Foundation Hospital, Mumbai. Dr. Ashwin Tamhankar, who is a consultant urological oncologist at Apollo Cancer Centre, Mumbai. Dr. Wasim Foplunkar, who is a consultant radiation oncologist at Hiranandani Hospital, Powai. Dr. Amit Joshi is a professor and a uro-oncologist at DMG Tata Memorial Hospital, Mumbai.
Can I have a medical oncologist on the panel? Amit is not there. Chirag sir, aa jaiye. Because the last paper is all about you, so thank you. Okay, so we'll start off. Thank you very much for the opportunity. If the sequence of them, the first 4 abstracts are about how to choose patients for the 6th abstract. So we are only trying to see what are the risk factors in patients whom we think we have cured them, so that we can identify the patients who might be appropriate for that very expensive drug, pembrolizumab. So let's see whether we can decipher whether we know any more than what we know now. So this one, the 3 abstracts are going to be about imaging, prediction, and prognostication. I learned a lot by preparing for this one. So I'm just trying to go through this quickly. Ashwin, what do you use among these one currently that you think are useful in assessing fitness or prognosticating?
So just the ECOG, honestly speaking, if I may say.
Okay, even in radical nephrectomy patient?
Yes.
Still ECOG. Do you use anything else? Does anyone use anything else?
Clinical impression is one which I will obviously add.
End of the bed analysis. Okay. Would you use anything else?
I also want to add the sarcopenia and the clinical impression.
Okay.
These 2 I would like to also add while in the treatment option.
Okay. You won't use gait speed, albumin level, CRP. There was a very good paper that was presented saying that CRP is important, but you haven't used. So let's see at the end of our talk whether we add anything more. So the C-reactive protein, take any cancer, you will find evidence that there is some evidence that C-reactive protein is important. And the reason why it is important, it just tells us that there is something that is happening in the background. So this was 154 patients. So you can say that that's not a large cohort and a bit more recent study. And what they have found is, if they have got it elevated before, if they were elevated before and it comes back as normal, they are good. If they are elevated and continue to be elevated, they are bad. And if they are normal, they are good. So the baseline is, if they are normal, they remain to be normal. If they are high and then becomes normal following radical nephrectomy, they are second best. And then the worst one is, they are high and then they remain to be high. CRP, is that convincing enough? I'll go for the... Do you think that's good enough for you to say that I would do CRP
if we compare,
sorry?
If we compare the disease like breast cancer with renal cancer, in breast cancer we have complicated analysis like oncotype DX21 and so on and so forth. While for renal cancer we have very simple. For advanced it is MSKCC or IMDC criteria, and for deciding on adjuvant therapy or perioperative outcome also we have simple criteria. So this is one of the several criteria. We just have to figure out that how best to choose the criteria for prognostication.
Okay, I'll ask the same question again. Would you use CRP then, or you won't use?
There is no problem in using it. Just a simple test.
So it's available, it's simple enough, so you would use it. Keval?
Exactly.
Yeah, one more point, sir. See, in Indian population, we find that normally just because of any sort of inflammation, because CRP basically is an inflammatory marker, so we can false positive cases will be too high for it to So before we incorporate into any kind of this risk scoring system, we need to have some further strong data for it.
I would probably this one. So it is known to be even higher incidence of cancer in patients. So if you do a population study, people who have got a higher baseline CRP, there is a higher incidence of cancer in them. And prostate cancer is low in them. I don't know why, but in population-based studies who have got high CRP, low prostate cancer, but colonic cancer is higher, breast cancer is higher, and they tend to do worse after the surgery as well.
Even any inflammatory conditions, CRP will be elevated.
No. So for 154 patients, I'm not going to say that that is practice changing, but in case if you do it, it just gives you a hint that there is something happening in the background. So do we already know it? I think we knew that there was something happening. Does it change my practice? If it was high and if it becomes normal, that's a bit more reassuring. But if it was high and continues to be high, you would like to know whether there was higher risk factors, and probably it helps you to say you might keep them under closer observation. You would not give them adjuvant treatment, but you would keep them under closer observation.
One more point. At what duration after the surgery we are doing CRP?
3 months.
Okay.
What's the T-half? Just out of the blue, I don't know. What's the T-half? Because it may be relevant as well.
I'm not that intelligent. Or I won't know. Okay, so lymphadenopathy, I'm just going to ask quick questions. Keval, lymph node in dissection in localized, do you do it? Yes or no?
No, sir.
No, okay. Mahendra, lymph node in clinically negative radical nephrectomy?
No, not do.
Okay, in clinically positive radical nephrectomy, and would you take out all the lymph nodes, or would you just sample what is you can sample?
If it is negative, always I do hilar lymphadenectomy.
Okay.
As a standard practice. If it is positive, I do RPLND, complete RPLND.
Okay.
Without mediastinal node, I don't do.
Why do we do it, Ashwin?
So it's more of a prognostication. That is what we know from Blood's criteria and other papers.
So only prognostication.
As of now, and now correlating the data of say pembrolizumab adjuvant, probably we can select the patient who is fit for adjuvant therapy.
So if you had lymph node positive disease, you would say that there is a higher reason or a...
Probably I'll put him on adjuvant therapy later on, another 2 years from now maybe.
Okay, if he survives. So there isn't any sort of curative role, there isn't any importance with respect to longer survival, you are doing it just for prognostication. So this one was quite a large cohort of patients, and lymph node size of, I don't have a radiologist to say is lymph node size of more than 1 centimeter good enough. But I could not, probably Vivek could understand this, but I could not understand the term 70%. Because if you see the risk there, it says 12%, 5.2, 3 and 7. And here on the left side, it says risk of a retrocaval lymph node being positive, clinically positive to pathological positive is 70%. I could not find any evidence of that in any other papers. All of them maximum go up to 50%. Irrespective of whatever lymph node size they are, they say it goes from around 15 to 50%. But when I saw the 70 number without being substantiated, I could not understand how they came with that concordance. Yes. They didn't quote the number. So the thing that was there, if you do numbers that I could take home was, when you do a CT scan imaging with respect to renal cancer, around 18% of them will have lymph nodes which are more than 1 centimeter, which is one number to remember. And among the lymph nodes, again, they didn't differentiate between right and left side. A right-side renal tumor with a retrocaval lymph node is different to a left-sided renal tumor with a retrocaval lymph node. They didn't differentiate between right and left. So I was more confused rather than being guided. The only thing is that lymphadenopathy is not lymphadenopathy. Probably you need to give importance to where they are as well. Yes? Does this add anything more to your practice, Mahendra? Would you be next time you look at and there is a retrocaval lymph node, you would say, yes, I definitely need, it's a left-sided renal tumor, there is a retrocaval lymph node, you would say, I definitely need to go and get it.
If it is 1 centimeter and retrocaval nodes are not involved, definitely I will not go for the retrocaval nodes.
Sorry, say that again.
If it's left-sided tumor
yes,
and intracaval nodes are not involved, there are no node, I will not touch the retrocaval node.
So it doesn't change your practice. As far as the EAU 2022 are, in an organ confined, don't do an extended lymph node. During nephrectomy, remove clinically enlarged lymph nodes. And we are doing it mainly with respect to prognostication. Though retrospective studies suggest clinical benefit associated with lymph node. The prospective RCTs, as well as quite a few controlled studies, haven't shown any benefit. So with respect to the lymph nodes, it just says that lymphadenopathy is not just lymph. Do look at it, but I don't know what will I do if I look at it. Did you already know about this, or does it change your practice, Mahindra? No for both? Or you knew that already and it doesn't change your practice? This one is the most important one. I had to read quite a lot about it because I didn't know what sarcopenia meant. I knew what sarcopenia meant, but I didn't know how do you categorize them. And albumin we always knew. Whenever, even in operative patients, if low albumin just indicates that they are malnourished and the healing would not be good enough, and probably long-term the outcomes would not be good enough. Did they select a good enough cohort of patients? Sarcopenia has been studied, every cancer has been studied in head and neck cancers, studied in breast cancers. It's a bit less with respect to breast cancer. The highest is with respect to upper GI cancers. So 103 tumor thrombectomies. Is that a right cohort to study it in? At least it's a start, especially with respect to renal cell cancer. And at the start of 51% had sarcopenia. In this study, they didn't actually specify how did they assess the sarcopenia, but I'm just going to give you a bit more understanding on it. So if you take those two factors, sarcopenia is the most important element. So if you look at the very high risk, wherein the patient is sarcopenic as well as hypoalbuminemic, there is almost 7-fold increase in their mortality. And it's the same. So whenever sarcopenia is there, they tend to be performing poorly. Then the next question comes, how do we measure it? It's quite easy compared to what I thought it would be. There are lots of intelligent ways of doing it, but I leave that to the medical oncologist. What is a surgical way of doing it? So there are these three: skeletal muscle index. So this is all appendicular skeletal muscle measured on DEXA scan. Again, it's an additional investigation, so I don't want to do it. Total muscle index is easily done. So what do you do is, at the level of L3, you do take the surface area of the psoas muscles and the paraspinal muscles. And if you want to do the total muscle, you take even these muscles, the rectus muscles and the abdominal. You just draw the area in centimeter squares divided by height in meter square. There is now the newer one, which is the psoas muscle index, which has been shown to be equivalent to any of the other more intelligent ones. So it's the same. You just draw these circles around in centimeter square divided by height in meter square, and it gives you an index. And quite a lot of, even in this one, there are 3 abstracts. So I just chose an abstract that was there. So what they did is, in patients who had sarcopenia before and after, so they assessed it before in the scans that were done for the kidney, and at 3 months follow-up. And if somebody continued to lose it, then they were much worse compared to somebody who remained stable or who improved. So when you look at these numbers, the people who have got worsening of the sarcopenia, they tend to do worse with respect to the survival probability. And we do these scans every time. CT scan that is done across the abdomen for all kidneys gives us a psoas muscle index, which is as good as the other ones. But at least it's a start. It gives us an understanding, a newer parameter for us to assess the overall fitness of the patient. And this has been shown to be useful even in response to nivolumab. There are other 2 abstracts that I haven't. So there are 5 abstracts just based on this sarcopenia index. So asking the question, we'll start off. Did you know already about this?
So we already knew regarding the investigations about sarcopenia, but we like practically we never use it. We use more of like BMI and ECOG status, as he said. So we don't use it, but yeah, I knew about it. Still, one question arises in my mind is that the authors categorized according to the risk categories of sarcopenia and hypoalbuminemia. So they say that if it is high risk, then it is sarcopenia but no albuminemia. So if preoperatively we correct albumin, is it going to change the prognostic status?
No, okay. So the albuminemia has been downplayed in this one. What they are saying is sarcopenia is more important compared to albumin. Though we tend to use albumin.
They categorize it high risk and very high risk.
No, they have used it, but actually they haven't found any correlation. So when you use only them as single factor, sarcopenia had almost worsening by 6, whereas albumin did not matter that much. Whenever you included sarcopenia as a part of the overall risk stratification, it mattered. So indicating that sarcopenia, which we were not using, is a bit more important compared to albumin, which we have been using. Did that make sense?
Yes, sir.
Raghu?
It has been studied extensively in other cancers, as you rightly said, but in RCC, probably it's new to me.
Yeah.
It is probably something to do with the immunological status of the patient, not just sarcopenia and hypoalbuminemia. Overall immunological status, this being an immunological tumor, it is probably something to do with that. Definitely, we are going to learn from these things. We are going to adopt this.
When I was trying to look for what is the psoas muscle index for Indians, there isn't any background data. Like all these patients who have any baseline, a 50-year-old having a abdominal CT for something else, we can probably have, we don't know what is our normal for us to say what is abnormal. So we don't know the sarcopenia definition for Indians, we use the Western ones. So probably a startup would be knowing what is our normal and then we say what is abnormal for us. So does it change practice for me? It makes me look at the CT scan in a bit more detail, especially if there is a follow-up one. So when I see the pre-op one and post-op one, it doesn't take a lot of effort to work out the surface area of the psoas muscle. And it gives me a hint saying that either the patient is being well-fed or exercising better. It's an easy number for me to remember.
Can be used for other stages also, not only IVC thrombus.
Everything.
Can be any
yeah, so that's why I started off saying that is that the right cohort to work on? Probably in metastatic prostate cancer.
But then, sir, we need to get a CT scan at 3 months for every patient.
6 months. Whenever you are going to follow them up. They used a 3 months one, but you can use a 6 months one. Okay, so this one, T3A are all of them equal? All the factors are equal. I've got another 5 minutes to go. I'll try to wind up before that. Oncological, are all the factors of T3A the same? So for all learned people as well, just to highlight it. So a T3A would be either a renal vein segmental involvement, pelvic calyceal system, sinus fat, or perirenal fat. So those are the ones that are stratified as T3A, though we don't tend to say 1 factor or 2 factor or 3 factors. The numbers that were important to me in this one was these were considered to be cured. So the patients underwent a radical nephrectomy and then they were followed up. If you look at the numbers over a 5-year period, 20% mortality, which we don't tend to quote. So for a T3A patient who has undergone a radical nephrectomy, the chance of them dying of the disease is 21% in 5 years. And almost it comes up to around 55 to 60% that there would be some disease-related event in somebody whom we think we have cured. वहाँ पे है यहाँ पे? Okay, so this has already been alluded to. What they are saying is the ones that have got perirenal fat involvement among these 3 is the worst one. And if there is more than 1 factor, it is much worse compared to having one of the individual factors. So the easiest one is renal sinus fat involvement have got the best prognosis, followed by renal vein thrombus, followed by perirenal fat involvement. And if they have more than 2 factors, they are worse compared to having 1 factor. Ashwin, does that change?
So doesn't change to a large extent, but I would probably ensure in my summary that it is T3A because of 1 or 2 factors, which we generally do not tend to in a follow-up section. So probably I'll make it a point that I write everything about T3A disease.
And the other thing that I thought was, let's say that if they had 3 factors or 2 factors, then with probably a bit more data or a bit more molecules coming in the adjuvant one, you would consider. It's similar to high-risk prostate cancer. When there are more than 1 or 2 factors, you know that they are going to have a recurrence. Same way here. So
I was just curious about knowing the reason why perirenal is more adverse than the, because central probably will be central will be more aggressive than the peripheral, but it's the opposite.
Santosh probably would be a better person to answer. Whether they are, madam, why do you think is morphologically they are different, hilar fat involvement to, or a sinus fat involvement to perirenal fat to a renal vein thrombus?
For sinus fat involvement, we take a section from the sinus, and that has much more prognostic impact, because sinus is a very rich area in vessels and lymphatics.
So at least in this one,
so
you might.
For every radical nephrectomy specimen, there has to be a separate section from the sinus.
No, ma'am. What I was saying is, in this study, what they said is sinus fat has got the best in the T3A, sinus fat has the best prognosis, followed by renal vein involvement, followed by perirenal fat involvement, or more than 2 factors.
Well, I'm surprised about this because according to me, the sinus fat involvement has much more prognostic impact on the oncologic outcome rather than the other factors.
Okay. So
That's
for you, morphology, you would think that's what it is. I was surprised as well, but that's
maybe the
what
timelines, because medial side tumors will present a little early because of some symptoms of bleeding or something of that sort, and the peripheral ones may be there in the body for a longer time.
Another point is exactly from where one is taking the section of the sinus. That is also very important.
Second, sir, I think we don't know the size of the tumor. It was more than 10 centimeter, more than less than that. Also, that may be the factor linked with the decreased survival.
So when they looked at only these factors, expecting that there would be similar number in all of them.
We are expecting it, but we don't know exactly.
No, it was just for me as a learning point to say that it's not just T3A. What makes it T3A is important. And in this one, I just wanted to highlight this. Probably this is the largest series of recurrent renal retroperitoneal excision. So I just wanted to highlight a number which was here. So even in patients who have had recurrence in the retroperitoneum, you are still giving a median survival of almost 6 years. So it is not that they are all going to die. So when you go, so median time was 24 months. So from the time of surgery, you are looking at around 7 to 8 years. Okay. So following retroperitoneal excision, a cohort of patients had adjuvant treatment, but irrespective of that, 50% of them will survive for at least 6 years. That was because we are not going to have this large a series. Probably China made, I would have resected 1 or 2 in my lifetime, and they have got more than 100 patients in this cohort. So I thought, what were the learning points in that one? With the increasing role of adjuvant, whether we are going to have these recurrences, we don't know. Okay, Chirag sir, up to you. Is this convincing enough for you to, the paper is published?
So, if I have to give the answer in one word, the answer is yes.
Okay.
Right?
The second one, like when we say for prostate cancer, metastasis-free survival, we know is almost as good a surrogate marker as overall survival. Can we say the same thing with this, with renal cell cancer?
Not always. It has to come sometime down the line. DFS, disease-free survival, is expected to be a surrogate for overall survival. But for overall survival, we have to wait for a long time in the diseases like renal cell carcinoma, prostate carcinoma, breast carcinoma, so on and so forth. If it was bladder carcinoma, it would have been easy. I mean, at the end of 3 years, I would have accepted the data. Okay. But in renal cell carcinoma, I will wait for a little long. But the primary endpoint, if you look from the statistical viewpoint, the primary endpoint here was disease-free survival. It was not overall survival.
DFS
so it has been met. Yes. Right? The other thing is that we desperately need some adjuvant therapy, because otherwise 1/3 to half of the patient with high-risk features are going to have a recurrence, and we need to prevent those recurrence. We need to have a good model to find out who these patients are and what drug do we use.
I'll just, in this one, in the subgroup analysis, which one is the most convincing one for you to use?
So, of course, M1 NED is the most convincing group.
Most convincing.
Yeah.
So, for M1, when you have resected everything, probably those are the best cohort.
True.
To at least if you were considering. Raghu, anything to add?
Sanjay, there was a recent article in EAU about role of radiotherapy in such retroperitoneal recurrences. Because it is predominantly at that point of time, if it is confined to the retroperitoneum, giving high dose radiation with a curative intent. Yes.
Yes.
So the financial toxicity is less, and even the toxicity of radiation is relatively less compared to adjuvant. Should we think of those things?
So I think one point, treating a recurrence locally is one thing, and treating with systemic therapy is another thing. I mean, in systemic therapy, we want to prevent the distant metastasis and to prevent the death from distant metastasis.
Thank you. So just to add, offer adjuvant, this is the new addition to 2022, that's one. And the take-home message, T3A components and more than one component is important. Sarcopenia and persistently elevated CRP are important. Probably sarcopenia is more important. Location of the lymphadenopathy is important. and adjuvant treatment will be the next step change in the RCC. How do we select the patient? How do we take the financial burden? We have to think. One sentence.
So Aman pointed about the cost. Extrapolating that, we know that probably it's a time to revisit adjuvant therapies from the TK era.
Yes.
So extract showed some positive data. So are we justified to use sunitinib in that particular segment just to give benefit of doubt when you have one trial which showed positive?
Okay. Chirag, closing statement.
So we just have one trial which was positive. Sunitinib duration was...
No, is that a good enough reason to give sunitinib?
Ultimately, it has to demonstrate the survival advantage, which it has not.
So currently, there is no indication. Thank you very much.
Yeah.
1 minute ahead.
Thank you very much.
Thank you very much.
Thank you very much, Dr. Sanjay Adla and all the panelists. We now move on to metastatic renal cancer, and I invite Dr. Taha Sejjiwala, who is a consultant medical oncologist at Mumbai Oncocare Indore, to present the next two abstracts. Dr. Taha, a sincere request, please finish within time. Thank you very much.
So, hello everyone. First of all, I'd like to thank the organizers. So, the first abstract is on immunotherapy-based combinations in first-line treatment of metastatic renal cell carcinoma with sarcomatoid features, a systemic review and network meta-analysis. So, all of us know that ICIs have been the change in RCC. But sarcomatoid feature is something which is aggressive and really troubles us. Now, despite therapeutic interventions, metastatic RCCs with sarcomatoid interventions, we are not exactly sure of what treatment will really help. So this was a systemic analysis of all the randomized trials to show us if which combination of ICIs would really help. So multiple databases were used of phase 3 RCTs, where first-line ICI-based combinations were used for sarcomatoid variants in renal cell carcinomas. 5 trials with 568 patients were included in the meta-analysis. Primary endpoint was PFS and OS, and the secondary endpoints being ORR and complete response rates. So coming to the results, 4 main points were analyzed: PFS, OS, ORR, and CRR. If you talk about the analysis of PFS, nivolumab plus cabozantinib, atezolizumab plus bevacizumab, nivolumab plus ipilimumab, pembrolizumab plus axitinib, and avelumab and axitinib. So all these 5 combinations have shown good results. When you talk about the PFS, especially nivolumab with cabozantinib has been better compared to others. If you talk about the analysis of overall survival, nivolumab plus cabozantinib, nivolumab plus ipilimumab, and atezolizumab plus bevacizumab, all 3 have shown significant results, with nivolumab plus cabozantinib is relatively better compared to the other 2. Talking about the overall responses, nivo plus EP, nivo plus cabozan, avelumab plus axitinib, atezolizumab plus bevacizumab, and pembro plus axitinib, all 5 have shown better responsive, and nothing per se is better than the other. Talking about the CRR, nivo plus EP resulted in significantly higher CRR. So concluding, sarcomatoid variant are responsive to ICI-based combinations. A dual ICI with nivolumab plus ipilimumab improved all efficacy outcomes and achieved the highest complete response rates. Although the association of nivolumab plus cabozantinib with CRR was not statistically significant, this combination demonstrated the highest likelihood of a PFS and OS improvement. Thank you. Coming to the next. Now, this is a prognostic model of upfront cytoreactive nephrectomy in patients with metastatic renal cell carcinoma treated with immune checkpoint inhibitors and or target agents. So during the cytokine era, we are pretty sure that upfront cytoreductive nephrectomy helps. After the TKIs came, we were not sure the two trials, Carmina and the other one, we were not able to really come to a conclusion. Now this is studied and to see if cytoreductive nephrectomy plays a role with immune checkpoint inhibitors. So the aim was to study, to investigate prognostic factors and to establish a prognostic model whether cytoreductive nephrectomy will be beneficial. So they did three things. First was they divided 400 patients into three groups: upfront cytoreductive nephrectomy, non-upfront nephrectomy, and third was the recurrence patients after the nephrectomy. Second, what they did was patients who underwent upfront cytoreductive nephrectomy, patients' background and overall survival was compared with those in the other two groups, and the prognostic factors were analyzed. Third was a prognostic model for upfront cytoreductive nephrectomy was established. Coming to the results, median observation period was around 25 months. Factors like clear cell histology, performance status, single metastatic organ, normal pre-treated C-reactive levels, and intermediate risk IMDC model. So all these were significantly higher in patients with upfront cytoreductive nephrectomy. Also, if you look at the 50% OS, upfront cytoreductive nephrectomy versus non-upfront, so it was better with patients who underwent upfront cytoreductive nephrectomy. Two important factors, that is multiple metastatic organs and KPS less than 80%, were independent factors for overall survival benefit. So looking at the OS, 50% OS, if patient has no risk factor, he had a survival of 43.4 months. With one risk factor, he had a survival of 29.1 months. And two factors, it was around 7.7 months. Thank you. So coming to the conclusion, upfront cytoreductive nephrectomy group was able to be stratified by a prognostic model into three subgroups with different prognosis. And this model can provide useful information for making decisions in consideration of upfront cytoreductive nephrectomy in patients with metastatic RCC. Thank you.
Thank you very much for completing within time, Dr. Taha. By Dr. Ɂagship, who is a consultant medical oncologist at Mumbai Oncocare Centre, Kemp's Corner. She'll be presenting the next two abstracts, and ma'am, please mind the time. Thank you very much.
Good morning, everyone. Today I'll be presenting two abstracts. The first one is the long-term PFS from TIVO3 trial, which is a trial of this TKI called tivozanib versus sorafenib in relapsed refractory advanced RCC. So tivozanib is a potent and highly selective VEGFR inhibitor. It's a TKI which is used in the management of advanced RCC. So TIVO3 is a phase 3 study which was designed to compare the efficacy and safety of tivozanib versus sorafenib in the patients who have received multiple lines of TKIs, that is in the third line or fourth line settings. So here, the subjects who were pre-treated with multiple lines, they were who have failed 2 or 3 prior systemic regimens. So they were given either sorafenib or tivozanib. And here they were stratified into 1:1 ratio, and the stratification was based on the IMDC risk category, that is favorable, intermediate, or poor prognosis, and also on the basis of prior therapy received, that is whether they have received 2 TKIs, TKI plus checkpoint inhibitor, or TKI plus some other therapy. So here advanced RCC patients were taken who had progressed with good performance status, and stratification and randomization in 1:1. So one group received sorafenib 400 mg BD continuously, and another arm, the patients received tivozanib 1.34 mg QD, which was 3 weeks on and 1 week off in every cycle. And treatment was continued until unacceptable toxicity or disease progression. So here, 2 arms were balanced for demographics and prior cancer treatment. In this, the 60% of patients had 2 prior lines of therapy, 40% had 3 prior lines of therapy, and 26% had previous treatment with checkpoint inhibitor. So here the patients who were receiving tivozanib, they demonstrated PFS superiority as compared to patients who were receiving sunitinib. And that is the 5.6 months versus 3.9 months. ORR was 18% for tivozanib arm and 8% for sunitinib arm. For about the side effects or adverse effects, 44% of patients who were receiving tivozanib experienced grade 3 or grade 4 treatment-related adverse effects, and 55% in sunitinib arm. So adverse effects were more in the sunitinib arm. And so here we can see that tivozanib is better in terms of PFS, and when in terms of OS, initially sorafenib is better, but with the long-term follow-up, this tivozanib is tending to get better. So tivozanib demonstrated clinically meaningful and statistically significant improvement in ORR and duration of response, and in patients with refractory or relapsed RCC. Median duration of response was around more than 1.5 years, that is around 20.3 months with tivozanib, and statistically significant improvement in PSS and ORR, which was shown initially, continues with the longer follow-up. And OS relative to sorafenib continues to improve with longer follow-up. So collectively, all this data confirms that tivozanib is tivozanib-based treatment option. It is a good option for these refractory cases of RCC, including those who had progressed on previous checkpoint inhibitors. So tivozanib is superior to sorafenib as measured by PFS, 2-year PFS or ORR in heavily pre-treated patients, and also it is better tolerated than sorafenib. Another topic is combination therapy for metastatic RCC. So here there is a systemic review and network meta-analysis which was done. So in the past decade, there has been a substantial changes in the management of metastatic RCC patients, and these immune-based therapies are replacing the targeted therapies. And broad range of combinations have been approved, but the comparisons of their safety and efficacy are still needed to guide the optimal choice of the first-line therapy. So here, in the trials, it has been shown that combination therapy is superior when compared to single agent TKIs like sunitinib alone. So one of the meta-analysis was done here where they did the indirect comparisons of efficacy and safety. They performed a meta-analysis of combination therapy, that is checkpoint inhibitor plus exitinib or bevacizumab, and provided rank order preference based on the PFS and AEs, and they compared it with sunitinib and amongst themselves. So here a total of 3 studies consisting of 2,672 patients were selected. In this, all combination therapies improved PFS when compared to sunitinib alone. The rank order for PFS showed the combination of pembrolizumab plus exitinib had the highest probability of favorability, followed by avelumab plus exitinib, followed by atezolizumab plus bevacizumab. PA combination was better than AA combination, which was better than AB combination, and all 3 were better than sunitinib alone. For AE, for adverse effect, pembro-exi had the least AEs. So this meta-analysis showed combination of pembro-exi should be preferred. There is one more meta-analysis in which the 6 phase 3 trials were included, consisting of more than 5,000 patients. And here they showed nivolumab plus cabozantinib had the highest likelihood of OS benefit in intent to treat population. Avelumab plus exitinib had highest likelihood of OS benefit in patient with high favorable risk. Pembrolizumab plus exitinib had OS benefit in patient with intermediate risk. Pembro plus Lenva combination had OS benefit in patients with the poor IMDC poor risk category. And regarding the adverse effects, the highest side effects, the adverse effects were seen in Pembro Lenva arm, and surprisingly the lowest adverse effects were seen with Nivo and Ipilimumab arm. The health-related quality of life consistently favored Nivolumab and cabozantinib, Pembro Lenva, and Nivo-EP combinations. Thank you.
Thank you, Dr. Seema Jagyasi. I now invite Dr. Smith Sheth, who is a consultant medical oncologist at MOC Thane, to present the last two abstracts. My sincere request to Dr. Smith Sheth to keep the time. Thank you.
So, hello, everyone. I'll be presenting two abstracts. The first one is the role of nephrectomy in metastatic RCC patient in the era of immune checkpoint inhibitor combination therapies, and this is a meta-analysis. So, as we know, immune checkpoint inhibitors combination therapy is the standard of care in first-line metastatic RCC patient, but unfortunately, we don't have any phase 3 data as of now to assess the impact of cytoreductive nephrectomy for efficacy in metastatic RCC patient. This study had assessed the role of cytoreductive nephrectomy in metastatic RCC patients in the immune checkpoint inhibitor therapy era. So the study included these 6 studies, which were the inclusion criteria were those comparing OS and PFS in the metastatic RCC patients treated with immune checkpoint inhibition combination therapy. So we had all the first line trials which are presented till now. The result is the immune checkpoint inhibition combination therapy was associated with significantly better OS and PFS compared to sunitinib that we know. And the benefit was across both patients who had undergone cytoreductive nephrectomy as well as those who had not undergone upfront cytoreductive nephrectomy. Although the OS and PFS benefit of the ICI combination therapy were larger in those who had undergone cytoreductive nephrectomy, the hazard ratio for OS and PFS indicated that ICI combination therapy treatment effect did not differ substantially with or without cytoreductive nephrectomy. So ICI therapy, whether patient undergoes cytoreductive nephrectomy or not, we need more data for that. In the network meta-analysis, Nivo plus cabozantinib was most effective regimen in patients undergoing cytoreductive nephrectomy, and Pembro plus lenvatinib was effective regimen in those not undergoing cytoreductive nephrectomy. So this table confirms what we had, what I had just spoken, the association of overall survival and treatment, and we can see immune checkpoint inhibitors doing much better than TKIs, and in patients who have undergone cytoreductive nephrectomy, nivolumab plus cabozantinib doing much better, and those without cytoreductive nephrectomy, we can see Pembro plus lenvatinib, the clear trial having the best hazard ratio. So cytoreductive nephrectomy offers survival benefit in metastatic, offers some survival benefit in metastatic RCC patients receiving ICI combination therapy. Careful patient selection remains paramount, and as we had seen that ICI combination regimen, they vary depending on the effect in those patients who had undergone cytoreductive nephrectomy versus those who had not undergone. So maybe we can consider this criteria of whether patient has undergone cytoreductive nephrectomy or not in selecting the first line treatment in metastatic RCC patient. So the next study is an interesting study, and we had had few presentations earlier also, and the study is the predictive impact of early changes in serum C-reactive protein levels in nivolumab plus ipilimumab therapy for metastatic RCC patient. So as we know, serum CRP level is associated with metastatic RCC outcomes, and however, in the era of immune checkpoint inhibitors, the predictive role is still unclear. So this study, the authors investigated the predictive impact of pre-treatment CRP level and early changes in CRP level after 3 months of therapy in metastatic RCC patients which are treated with nivolumab plus ipilimumab. So 48 patients were enrolled. First, the patients, so there were 48 patients who had undergone CRP levels, And these patients were divided into two groups, initial CRP more than 1 and initial CRP less than 1. And the progression-free survival was compared between these two groups. And then secondly, based on CRP change, after 3 months of Nivo-EP treatment, the patients were again subdivided into three groups. The normal group, where the CRP remained less than 1, normalized group, where CRP initially raised had decreased to less than 1, and non-normalized group, where the CRP did not come back to, was more than 1 even after 3 months of treatment. The predictive association between CRP and PFS was measured. So this is the graph, and patients whose CRP was more than 1 at baseline fared much poorer and had inferior survival compared to those with CRP which was less than 1 at the beginning. And then after 3 months of treatment, the worst survival again was patients who in the non-normalized group, in which the CRP had not come back to baseline. And the second best group was the patients whose CRP level came back to normal after 3 months of treatment. And the best survival was patients with CRP level less than 1, even at the baseline as well as post 3 months of treatment. We can see the overall response rate was better in the normalized and normal group. It was 81.1% in the normalized group and 57.1% in the normal group. I think they compared CR plus PR as overall response rate, and stable disease was not included. So the results were the PFS, as we had seen, was significantly higher in high initial CRP group. PFS was significantly lower in high initial CRP group, 4.3 months versus 28.1 months. And as for the early CRP change, the normal and the normalized group had a progression-free survival of 28.1 months versus 11 months compared to 2.7 months in the patients in whom the CRP did not return to normal. There was no significant difference between the normal and the normalized group. And the overall response rate, as we had discussed, was higher in the normal and normalized group. In the Nivo-EP therapy for metastatic RCC, early changes in CRP could predict progression-free survival. This data may be useful for early detection of ineffective Nivo-EP therapy and conversation to subsequent therapies. Thank you.
Thank you very much, Dr. Smith-Chit. And now a panel discussion on Dr. Smriti is a senior consultant medical oncologist at Leelavati Hospital, Mumbai. I also invite the panelists, Dr. Kumar Prabhash, who is a professor and head of the Department Medical Oncology, Tata Memorial Hospital, Mumbai. Dr. Ashish Joshi, who is a senior consultant medical oncologist, MOC Borivali. Dr. Vashisht Maniyar, who is a senior consultant medical oncologist at MOC Ghatkopar. Dr. Devendra Pal, who is a senior consultant medical oncologist at Mumbai Oncocare Panvel. Dr. C.V. Pethe, who is a senior consultant medical oncologist at MOC Nashik. Dr. Santosh Vaigankar, who is a consultant urologic oncologist at Kokilabhen Ambani Hospital, Mumbai. Dr. Mahendra Pal, professor uro-oncology at Tata Memorial Hospital, Mumbai. Dr. Mangesh Mekha, who is a consultant medical oncologist at MOC Pune. And Dr. Sumit Basu, who is the head of the Department of Radiation Oncology at Kokilabhen Ambani Hospital, Mumbai. I hand over the session to you, ma'am.
I'd like to thank MOC for giving me this opportunity to moderate this panel discussion. A lot of things have happened in the field of renal cell cancer. You've just heard all the abstracts, and we quickly go to the discussion about these abstracts. So, first coming to the metastatic RCC with sarcomatoid features. So, I'd just like to start from Dr. Kumar Prabhash. What is your experience? What's the prevalence? After all, this is not a subtype, but it's basically a sarcomatoid differentiation of various histologies of RCC. So I think that has to be made very clear. So what is in your institute, the prevalence?
So often, ma'am, I won't know the exact number. Uncommon. If I put a number 2 to 3%, that may be something which may I remember. Maybe Santosh is there, he can add to it.
Or
Sangeeta madam is
she's
madam,
here.
Yeah. Infrequent. And more important is, till recently, if you get sarcomatoid, the reaction was nothing is there. at least for Med-Onc side. I'm not saying for other side, for our side. Now we have some good data. If the cost is not aside, now we are not as in despair as we used to be around a few years back for sarcomatide.
Yeah. I would just like to add one point. I'm here. One point is it's again all dependent on the sampling, because sarcomatoid area may just occupy one little area in that entire tumor, and that tumor may be 10 centimeter, and one section of 10 out of 10 may occupy sarcomatoid chain. So it all depends on sampling.
So now, as Dr. Kumar Prabhas said, that if a medical oncologist sees this report, the first reaction previously would be, oh, we have very little to offer, the prognosis is very poor. And how has it changed? So now I've given you all the options that have been looked at in this, and then we'll come to the actual paper. So what would be, you've heard the presentation of that paper. So considering that, what would be your selection, cost aside? I mean, what would be your selection for treating these patients?
Yeah, so I think, Madam, as you previously mentioned, it was used to be gemcitabine-based chemotherapy. That was what was there in the guidelines when I passed out of my DM. But now subsequently, I think we have got interesting data that there's something is working in this difficult to treat disease. Typically, I tend to use IO plus TKI. I know that there is a data which we are going to speak, but IO plus TKI would be my preference of choice in this group of patients.
Anyone else?
Yeah, actually, all the trials of ICIs, the incidence of the percentage of patients with sarcomatoid morphology is usually 8 to 10%. In one of the trials, it is 18%. And out of all these trials, nivolumab plus cabozantinib has shown best outcome as far as OS and PFS is concerned. Although we can use pembrolizumab plus axitinib also.
Yeah. So, anyone else would like to add?
I think in bygone ages, we used to use sunitinib followed by second-line chemotherapy based on doxorubicin. Nowadays, my choice has been cabo-nivo, and probably in second line, again shift back to chemotherapy.
And for those patients who cannot afford the IO, then which would be your drug of choice where as far as the TKI is concerned? I know we don't have any randomized data, but given that, what would you choose? Would you use sunitinib or cabozantinib?
Since we have an altered schedule of sunitinib, I think now it is much better tolerated than what it was 4 weeks on, 2 weeks off. 2 weeks on, 1 week off is better tolerated. With the price coming down, that has become my treatment of choice. Cabo, I feel, is not a very good tolerated drug.
Yeah, doctor, anybody else?
Yes? Cabozantinib has better data for sarcomatoid morphology. Right. So that should be the first drug. Even like with or without nivolumab, cabozantinib should be the first line.
Yeah, and you can adjust the dose. I know no one tolerates a 60 milligram, but you can definitely come down on the dose to 40, and then I think that is well. Dr. Kumar Prabhas and Dr. Joshi, if you want to share your experience.
Yeah, so I think the cabozantinib nivolumab trial has the dosing of cabozantinib at 40 mg. When it is used as monotherapy, it is 60 mg. So I think 40 mg is fairly well tolerated once we do it. So cabozantinib would be my choice for a sarcomatoid histology.
At TMH, what do you do now?
So 60 almost no one tolerates. 40 good number of patients we have to. It gets troubled, and patients, these kind of patients you see in different setup makes a difference. So that also becomes a challenge. Cabozantinib we are learning to handle well. Sunitinib we have learned. Cabozantinib we are learning to handle better. So we do that, ma'am. But not exciting till the IO comes. Sarcomatoid is something.
Right. Exactly. So IO is very important, and this is just to tabulate what was presented, that you looked at all the combinations, and you can see that the nivolumab and cabozantinib and nivolumab and ipilimumab almost across the board they are better than sunitinib. It's only that the CR rates are seen even with the dual IO combination, so that is important. Of course, it's very expensive, so that becomes the major hurdle, but otherwise that is a very good combination. And so the take home is that it is responsive to IO combination. Nivolumab and ipilimumab improved all outcomes with the highest CR rate, and nivolumab and cabozantinib has the highest PFS and overall survival, even beyond that of ipilimumab and nivolumab. So this is about the first. Now coming to cytoreductive surgery and nephrectomy, and here I'd like to call upon our surgeons, to take up some of these issues. So first of all, how do you select your patients for cytoreductive nephrectomy? And of course, in a later slide, I'll show that we do have some positive data now coming up. So what is your view on selecting patients for cytoreductive nephrectomy? Yes.
Madam, there are these models where we see the prognostic value, means if it is favorable risk or intermediate risk, but depends on the presentation. If you talk about intermediate risk, then depend on what METs the patient is. Got a lot of METs, then probably I won't go on the side of cytoreductive nephrectomy. But if it's intermediate risk with, say, a single MET, depending on whether it is amenable to resection or no, then I would definitely go ahead with cytoreductive nephrectomy. And depends on the majority of patients that present to us in a metastatic setting, as far as RCC is concerned, would probably tend to be more in an intermediate risk rather than somebody in a favorable risk. So if it is intermediate risk, then I'll look at other parameters also, like concomitant METs, number of METs, and that would probably help me to decide whether I'll go with nephrectomy or not.
Yeah, so that prognostic model which was presented, where they said, the number of organs involved and also the KPS score. Of course, we had a discussion with medical oncologists yesterday that we use the PS score rather than the KPS, so less than 80. So do you think that's quite a valid model? And you mentioned number of sites of involvement.
It could be. So we want things to be more simpler for us, so because we need to decide for the patient who's sitting in front of us.
Right.
So the simpler things for us to decide, the better.
Yeah, and yes.
This is the IMDC criteria which the doctor is talking about. So about low risk disease, intermediate disease, we can do a CN provided is operable, and the maximum number of METs disease burden we can remove it. And that is how to select the patient is very important in this scenario. So this model is very important to select us.
Yeah, and just one more question for the surgeons. Again, that was addressed in the previous discussion about retroperitoneal node dissection. So I think you could just answer that in short.
Again, if there is a minimal lung METs and we are able to achieve the R0 in the abdomen, then later on we can also remove the lung METs also. The patient doesn't need any type of therapy later on. So in this, if operability is very important thing, whether we can achieve that R0 or not.
Yeah. So now what do the medical oncologists have to say? Because the study was that has the introduction of IO combinations really changed the scenario as far as cytoreductive nephrectomy is concerned.
So there are two aspects, and I'll come to directly your question after that. One is removing the METs and removing the primary together is a bit separate issue than only doing cytoreductive nephrectomy. First part is good. If you can remove METs with R0 restriction with the primary, great idea, do it. You will prevent good number of people exposing to systemic therapy. Not a bad idea to do it. In fact, there is a data that adjuvant you can give IO, that one can make a choice about it. Now, coming to second part, that is you are not able to remove the METs and you do cytoreductive nephrectomy. There is an issue there. Now, what is the issue there? Interferon era, you have a randomized trial that cytoreductive nephrectomy improves life. Please do that in that era in case you are working in that era. You in TKI era, you have a randomized trial that it doesn't benefit. So your era changes. And during TKI era, before randomized trial, we had all these meta-analysis suggesting that cytoreductive nephrectomy improves life. Why? Because it is done primarily in the patient who are relatively fit, which has got a better prognosis. So the moment in a randomized trial, you take two groups, you're not randomizing, you're taking two groups where you did cytoreductive nephrectomy, you didn't. In meta-analysis, by and large, you will always get the patients where you have got cytoreductive nephrectomy, they do better. But there is a bias here when you're selecting the patient for doing it. The moment you randomize, then it becomes a trouble. So for me to think that in IO era, again we go back and thinking that it benefits, it is possible, we shouldn't close down that. But where for symptoms it is required, one should do it. Otherwise, be careful in your selection of patients when you do only for cytoreductive nephrectomy. For example, you have a 2 centimeter lesion in kidney and 10 tumors in the body all around. That interferon data doesn't stand true here. That is, if you have a 10 centimeter lesion with few mets all around and it is causing a bit of a pain, not a bad idea to remove.
And two quick points. One is the trials which looked at cytonephrectomy and TKI, they are plagued by poor patient selection with poor risk. But when you are doing, for example, if I'm doing a cytonephrectomy and there is a node, and if you see 2 patients, some patient may benefit it, some patient I have seen recur immediately after 3 months with a node positive as well as nodule in the area of resection. So we actually don't know what's the timeline of the patient. But if you're seeing a node there while you're doing a nephrectomy or an imaging, I think we should take it out.
Yeah.
Can I comment on that randomized trial? Sure, node we should remove. There's no doubt if you have some nodes, contralateral, please do it. If you want to remove lung mets, why not remove the nodes and have a R0 resection? Coming to the randomized trial, if you go to the subgroup, they did subgroup analysis, and I know that some of our surgical colleague hangs on that in the good risk patient, it didn't show inferior outcome. In intermediate risk group and the high risk group, both of them, there was inferior outcome if you do cytoreductive nephrectomy. To think about in the good risk group, it benefits is not a great idea. That doesn't mean I'm saying in good risk group, subgroup, which was not supposed to be done, it didn't show that it benefits. Be careful because, interferon era, why not? Other era, be careful. You can harm patients.
So same in IMDC, in Tata Hospital, IMDC, poor risk. We don't operate actually. Okay, but in future, if bite response is very good and tumor shrinks very small and notice that only kidneys have had a tumor, then we propose to remove the kidney in that case.
I don't know. This is very good idea. Oh, if you want to remove everything. Wait for some time. Talk to your med-onc colleague. Hey, you have a treatment where there is 70% responses. Now, we have not seen in kidney in the past. But you have 70% responses in kidney patients, then you can again go back to your surgical colleague. Hey, only you have a few lesions left. Can you remove it now? I do agree. Again, there is a merit there.
I think for want of time, we have to move on. So you can see that in this study, it showed that if you look at the overall survival data at the bottom, you can see with nephrectomy, it was slightly better hazard ratio than without nephrectomy, but it was too marginal. So that is why it said that the IO combination was effective irrespective of the cytoreductive nephrectomy. So this is what it said, but only thing, as was mentioned by the speaker also before, that cytoreductive may contribute to decision about choice of ICI because nivo-cabo is best in those with cytoreductive nephrectomy and pembrolizumab is better for patients without. But this is a very small group and this is just an assumption, but I don't think we can really put it into practice, but this is just one of the offshoots of this study. And of course, this is about the second one, so I think I'll skip this for the want of time. But I will just come to the present role. As of, I've collected all the data now. Interferon era, you said these are the positive studies. The anti-angiogenic era, the Carmena study was the one which gave a big setback to this concept. But if you look at the NCD data, which has been presented, and that 35% of patients with metastatic RCC treated with anti-angiogenic agents had superior survival with cytoreductive nephrectomy, and you can see the data there. IMDC data also presented at ASCO GU in 2021, less than 65, IMDC risk 0-1, no adverse histology, improved overall survival with cytoreductive nephrectomy. And in the IO era, there are no prospective data. The data presented here does not really support the cytoreductive nephrectomy, but read the last line, very important. Consider it in those with good performance status, one risk factor. In others, consider after systemic therapy after a good response. And I think we all agree that with the type of systemic therapies that are available to us today, you should not rule out a deferred cytoreductive nephrectomy. So I think anybody else disagrees with what is the summation. So let's move on now. So systemic therapy options, Just quickly, I think I got the wrong abstract because mine, the abstract that was given to me was related to the toxicity of the targeted agents. But what Dr. Jagyasi actually presented was which is the superior combination. So let's leave that aside. Let's go with what Dr. Jagyasi presented. So how do you select the first line therapy for metastatic RCC? So Dr. Pete and Dr. Pal, can you just tell us that?
I select my patients for treatment based on, for me, first always comes what money does the patient have in his pocket.
No, let's leave the
So if that we leave that
aside.
part apart, I've become more fond of using Pembro plus axitinib or Nivo plus cabozantinib. I've become more fond of using that. Again, I'll add to it, Cabo, I have had to dose reduced to 20 mg in many patients.
So does the IMDC risk stratification an important factor when you try to decide this? I know that there are combinations approved across all the risk groups, but I would like a comment on this because what about the low risk, you know? So, and have you really thrown sunitinib out of the window? So I just want to know, I'm saying economics aside, I know that most of the times we are using single agent VEGF TKI because of cost factors, but that aside, scientifically speaking, what is your view?
In the Nivo-IP trial, those patients with favorable risk, they actually performed bad on ICI combination. So Nivo-IP is not the combination for good risk patients. Nivo-IP can be used for intermediate or high risk. As far as other immunotherapies are concerned, pembrolizumab plus lenvatinib or pembrolizumab plus axitinib. So, they have shown, the trials have shown that the improvement is there in PFS in all subgroups. But definitely those patients with PD-L1 more than 1%, they have performed extraordinarily well. So I'll to rationalize it, I will like to use ICI combination, Pembro combination in patients who are more than 1% PD-L1. And Sutent may be given for patients, although in less than 1% PD-L1 also Pembro plus axitinib has shown very good hazard ratio, but it is not as good as PD-L1 more than 1%. So although can be used, but we can give the option to the patient.
Yeah, so madam, IMDC criteria has revised one, has got thrombocytosis as one of the important factors. So, and after that, whatever the studies have been done, for the low risk group, still I think single agent oral TKIs could be one of the options, and that also lingers in the NCCN guidelines, where for a low risk IMDC criteria, single agent sunitinib still could be one of the options. But definitely for a low risk, no IO-IO combo. It could be either single agent TKI or IO plus TKI.
And Dr. Kumar?
So I think a few things to remember, no, there won't be one straight answer, and most of us will be correct what we choose here. But having said that, one is sure risk criteria. Second is how symptomatic is the patient, because that may help. If you want good responses, like tumor burden is high, then you want good responses. Then you know cabozantinib plus TKI has got a very good response as compared to other. For example, if you have a low risk group and you have asymptomatic patients, we know in the past observation has also been an option, and I have exercised that option, and I'll tell you it is very satisfying once in a while, but I have done it. So in those patients, if I have to choose, I won't leave sunitinib as a complete out of the window, because again taking injection and coming every 3 weeks for years altogether is not a comfortable situation for the patient. When in second line, again IO works very well, but again choose your patient. So idea will be your risk group, idea will be how symptomatic is the patient, idea will be how is the bulk of the tumor in these group of patients, and that may help you decide which treatment and combination you're going to use.
Okay. Now just to go to the second abstract, and that was of itumelnant. So I just want to know, of course none of us have experience with that, but almost 3 years and 4 years progression free or long-term PFS in almost 10% of the patients, in those who have received prior 3 lines of therapy. So how does this compare with the subsequent therapies that are mentioned here in this NCCN guidelines? Yeah. No, see, we have second line therapies over here. So tivozanib is also mentioned. So I just want to know that how would you put that with the host of second line options that you have, given the data that was presented? There is no overall survival benefit. It's only progression-free survival.
The subsequent therapy regarding tivozanib.
Yes.
So, good option. I think so. I missed that part. So, maybe I'll not be able to come. Ashish?
So it was compared with sorafenib as the second line plus option. I think the responses are reasonable, and we also know that sorafenib is a very difficult drug to handle compared with, we don't have an experience of this particular TKI, but nonetheless one of the interesting options. By the time the patient will come to that, probably patient would have received IO plus TKI and one of the TKI as the second line, and that could be the third line treatment options. But yes, could be one of the factors, yes.
Okay.
Actually, these patients, they have used tivozanib in post 2 lines, means third line onwards. So that means they have not been exposed to sorafenib till that time, and they have been exposed to other TKI or maybe ICIs. So like after these agents have been used, and like not much options are left. If you have used TKI in first line, ICI in second line, like in first 2 lines, if you have used TKI or ICI, and sorafenib is not yet used. So I think that's if you select between, if you have to choose between sorafenib and tivozanib, I think that is a better choice than tivozanib, than sorafenib.
Should I stop or can I have some 2-3 minutes more?
Can have 2-3 minutes more, ma'am, because I think it's more food for thought.
Yeah, so I think...
Can I share a bit about that drug? So I missed that abstract, but there's a very interesting story about drug. This was students. It was tried in first line. It had a PFS benefit, which was the primary endpoint. OS was ulta, and FDA didn't give approval for this drug in a first line in the past. It was some time back. Just interesting.
So that was important information about tivozanib. Now, this is the last, so that's why I said just 2 minutes more. As opposed to what discussion we had in urothelial cancers and all, and many other cancers, are there any predictive factors? So this is what was brought up in the last abstract. So are there any predictive factors for understanding the response to IO? Anyone of the medical oncologists? Sorry, I have left the radiotherapist out. Yeah.
Those hardly anything for me, but I am on the panel enjoying it.
So, the risk group is the best predictive marker. I'll tell you the problem with this individual predictive marker. It was 48 patients. The problem is that whichever new marker you bring in, it should be over and above the existing marker. Now, that was not taken into the factor. So, for example, I'd say in lung cancer, why we think EGFR is a very good predictive marker? It is totally independent as compared to what is the gender, what is the smoking status, whatever it may be, it comes out totally good as compared to. CRP has been done in many ways, many places for as a predictive marker. It is an inflammatory marker. So if you take it alone, it comes out very good in many places. The moment you put it with 5 more markers, which is already known, then you realize it starts struggling. So it may turn out to be good in future, but that not may be the most
So
important.
this was the data shown regarding this, but as the point that was brought out, it's just a 48 patients data. It is important from the point of view that ipilimumab and nivolumab is a very expensive treatment. And if we could get a good marker to say that that's not working, of course those patients are going to do really badly. But if that's not working, then it would be a real great tool in the hands of medical oncologists. Yeah.
Just one point in favor of Dr. Basu is that there are some investigators looking into the idea of SBRT in patients who recur.
Yes.
So I'm sure he'll be having some more to discuss on when we take this topic up later on. But I just want to ask him anything he wants to put an idea or his thoughts about this particular concept being introduced in metastatic RCC.
Yes, please.
So SBRT with immunotherapy, of course, it's an upcoming, and we are now getting enough data on that. And although I don't have any experience as of now,
on this, but I'm sure in all the other metastatic diseases also, especially when this RCC being such a radio-resistant tumor. So there's definite role of SBRT and combination of chemotherapy is going to play a role. Definitely.
So you're talking of the abscopal effect of immunotherapy combined with radiation. I don't know, like how many times have we really seen it? It's talked a lot in the literature, but you know, in fact, in factual life, hard to come by.
That part I won't be able to comment. But what I'll comment, Vedang is not there. Otherwise, he would agree what you said. In the past, we thought kidney is a cancer, is a radio-resistant tumor, and we have been desperate situation. Mahendra is here, and I see Ganesh is there, Sir is there. We have been sending patients for RT to Vedang for palliation. You do have a good palliation. Now he has done some SBRT. I say slowly we are now realizing not necessarily kidney cancer is always resistant. The moment the dose goes up.
Yeah, so that is basic concept of radiobiology. The moment you achieve a good BED, biologically effective dose of beyond 100, you definitely get a response. So the idea of SBRT is to give highly localized high doses of highly localized treatment, basically. High precision treatment, essentially. So there you get the positive response there.
So with that, I'd like to thank the panelists and again MOC for giving us this opportunity to discuss this particular topic threadbare. So I really thank everyone. And I didn't have time to allow the audience to interact, but you're free to ask any questions when the panel is there. The time of the panel is over, but you can ask questions. Yeah.
Thank you, Dr. Smriti. May I request the panelists and Dr. Smriti and Dr. Sangeeta, will you also join for a picture? You've been patiently chairing our sessions from the start of the day, so we cannot avoid or neglect you. So we come to the end of this academic bonanza, and I'm sure it must have been an enriching experience, not only in terms of knowledge exchange, but also human-to-human interaction after the isolatory experience that we have faced in the last 2 years of pandemic. I would like to call upon Dr. Ganesh Bakshi to conclude the experience by proposing a vote of thanks to all those who have contributed to make it a successful event.
Thank you. I mean, you have been constantly talking about what has been happening in each of the sessions. So to begin with, thank you very much. It was a very nice mastering of the ceremony. And on behalf of both Urologic Cancer Foundation as well as MOC, I thank all the faculty. There have been so many faculties who have come for this program and contributed to this program. All the delegates who have been there for 2 days, and we really have a good people and a good discussion happening in all these sessions. I hope we carry all these enriching scientific thoughts and add up on our practice in some way or the other as applicable. So I also thank the AV team here. I thank the people, event managing people with us, and the trade who have been good in giving us academic grants to have this program in this way. So our contributors who have partnered with us are BMS, MSD, Roche and Zydus Pharmaceuticals. The others are Intas, Fresenius, Core Diagnostics, Sun Pharmaceuticals, Bayer, MQR, Cipla Oncology, DRL, Adley Pharmaceuticals, Merck, Glenmark. So with all this, we have a lunch after this, and maybe we would look into how this program went. Any suggestions would be incorporated, and we can think in a better possible way how we can update the science maybe next year. So thank you so much, all of you. Thank you for the participation.
Thank you, Dr. Bakshi. We pledge to return next year with more wisdom to share in our next wave, and wish you all a safe journey back home. Enjoy the delicious lunch. I take your leave. Goodbye and thank you. Have a nice day.
The certificates are on the desk outside, so if possible, please collect those remaining we'll try to send to people. Thank you so much.